आप हैं ना?
Sir, we are live, sir.
Yeah.
Yes,
Sarita,
yes.
let's start.
Okay.
Yes.
Dr. Manisha?
Yeah,
Yeah, please.
sharing the screen. Yes. Ashish sir.
Yes. So welcome to the ICOG Masterclass on labor and delivery. And first of all, I extend my heartfelt gratitude and thanks to all the office bearers of Foxy, Dr. Jaideep Tang, the President Foxy, ICOG, Dr. Parul Kortawala, our sitting chairperson of ICOG, Dr. Sheila Mane, Vice Chairperson ICOG, Dr. Madhuri Patel, Secretary General ICOG, and Dr. Sarita Valerao, Secretary ICOG. Myself as the convener and our co-convener, Dr. Durga Shankar Dash, is a bit sick today, and I don't know whether he'll be able to join or not. We have our two wonderful MOCs. We have 3 sessions today, and to discuss about the sessions, and I will hand it over to our MOC. But before that, I would like to welcome all of you with a few messages and inauguration from our chairperson, sir.
Yeah.
Thank you, Ashish. Now this is, I believe, 4th masterclass of this year.
Yes.
And third, okay. And masterclasses have been so very successful. They are one of the prime programs of ICOG with very high attendance. And I compliment all the coordinators for that, Ashish included. And today's chief convener is Dr. Ashish. Topics today are also all very important topics, day-to-day importance. Bridge presentation, I believe Ashish would be adding vaginal delivery, no? Ashish?
Yes, sir. Yes, sir.
Because it is labor and delivery.
Yeah.
Then difficult cesarean sections by Niranjan, pain relief by Dr. Sharika from Patna. And then we will have an excellent panel on induction of labor. This is also a very contentious topic because if you survey 10 obstetricians, there would be 5 different methods of induction that will come through. So it is better that we consolidate and plan 2 or 3. At a national level also, if we can do that, maybe over a period of time, we can collect data about comparing these 3 methods. So we can convey that these 3 would be the ideal or superior method for an year's time. Subsequently, we can review after 1 year whether to alter or not. And then Professor Piley will be talking on instrumental vaginal delivery. He has been an innovator and has developed his forceps and various instruments. So it will be very important topic. And one of the topic which is very close to my heart is alternative birthing positions. About 15 years back, I was visiting Sweden and I saw that they offer so many different positions to patient, and I've seen them delivering in various positions. Vertical meaning standing up, squatting, sitting backside, various positions. So we can use a cafeteria approach and offer all of them to the patient and let them choose would be the best way, because the lithotomy, which is very good for us, may not be the most suited for the patient. So today's sessions are all very important ones for practicing obstetricians, and something good will emerge through this. I wish you all a great webinar. Thank you, Ashish.
Thank you, Dr. Parul. And with those words, I think I will welcome a few more words from our Vice Chairman or Dr. Our Sarita Valera, our Secretary, and then we will start the session. Is Dr. Madhuri Patel here?
Yeah, so sorry to interrupt. I think before any beginning of any occasion
Yeah,
or any session, we
inauguration.
should always not to forget the Almighty. So with that, we should begin with the
Inauguration.
Shall I have to speak again?
no, sir.
Please let us get on.
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्युर्मामृतं गमय ॐ शान्ति शान्ति शान्ति.
Thank you so much. So as we know, Dr. Ashish Kumar Mukhopadhyay is our convener for this today's session. He is a principal and the professor in it, chief of Department of Gynae Obstetric, Chittaranjan Seva Sadan College of Obstetric, Gynae and Child Health, Kolkata, and also the vice president Foxy in 2016-17 year with governing council member of ICOG, past president BOJS, and also the ex-chairperson of Medical Education Committee, Foxy, and scientific chair of AICG 2022. Welcome, sir, for today's session. The next co-convener is Dr. Durga Shankar Das. Sir is a governing council member of ICOG 2024 for 2025, and also the governing council member of ICOG 2018-2020, and the chairperson for the Public Awareness Committee 2013 and 2015. He has a national coordinator for Foxy CME since 2011, 12, and 2014. He has various publications at national and international level and many awards too. Welcome, sir, for today's session. So I kindly request our convener, Dr. Ashish Kumar Mukhopadhyay, to welcome our dignitaries for today's sessions.
Yes. And as we know, Dr. Jaideep Tank, he has been a visionary in Foxy president this year, and he has got many achievements under his belt. And I'm not going to read his entire biodata because that will take more than my lecture time. So Dr. Jaideep Tank is here. Is he there to, is he present?
Nilima?
No, I think he's not there.
Okay. Okay, then let us move to the next. Dr. Parul Kottawala has been already introduced.
Yes, sir.
He has already given his opening remarks. And Dr. Sheila Mane, the ICOG Vice Chairperson this year.
Yeah, I think, thank you, Ashish. We will not waste time in introduction. All of us know. So I wish all the best. And I know that these master classes are very popular now. And I wish that more and more postgraduates get the benefits sitting in their own place. And I really congratulate the whole team for carrying on this program. Best wishes. Yeah, thank you.
It has been a passion for Sheila Bhimane to be associated with these kind of programs, and she is intimately associated with all these kinds of programs, and especially PPH. She has been named the PPH Queen in India. So we will move on to the next slide, please. Yes, Dr. Madhuri Patel is always a source of encouragement, Secretary General of Foxy, and also she was Editor-in-Chief of Journal of Gynecology of India, Jogi. She has a huge, beautiful career, and I've been seeing Madhuri for a long time. She's very sincere. Is Dr. Madhuri Patel here?
No, sir.
No, I don't think so.
Okay. That's okay. And Dr. Sarita Valera, our dynamite secretary this year, she has been very popular amongst the ICOG fellows and members, very humble, very polite, and down to the earth. She has been the immediate past president of the Mumbai Obstetric Society also. And she is a gynecologist associated with Bridge Candy Reliance, H&H, Saifi, Vatia, and Wadia Maternity Hospitals. Dr. Sarita, for you.
Thank you, Dr. Ashish. I think Dr. Parag Biniwale is there. And
Yeah,
may I request him to say a few words? Parag, are you there?
I
Yeah,
initially
I'm
thought
here,
his
but
name,
Sarita,
but
let's go on,
didn't.
go ahead with the program because people
Yeah,
are
I'll just
waiting.
say 2 lines. We go ahead, but
lines,
we want
yes,
you to.
Yes,
All
Parag.
right. So, good afternoon and happy learning to everyone. Today is something which is today's topic is something which is so close to everyone's heart because labor and delivery is the forte of the obstetricians. And today we are going to learn a lot of new things from experts, right from breech delivery to alternative birthing positions. So I'm sure it's a treat to listen to all these senior faculty. Thank you very much.
Thank you, Parag. Thank you so much for your 2 lines. And you have been always encouraging. And in ICOG, I have always seen Parag as my inspirer and my guru in all things, in everything, from academics to non-academics. Thank you very much. Next slide, please. Yes. I think they have been introduced to you, my two beautiful coordinators, come MOC, Dr. Manisha Varnekar and Dr. Mariam Khanam. They will conduct the proceedings today.
Thank you so much, sir, for handovering the session. So let's begin with the scientific session, which is of course a very important and as already discussed regarding the topic which are there for today's session by our convener. So let's move on with the scientific session. To begin with the session, we have 3 talks first, and first talk will be given by Dr. Ashish Mukhopadhyay. To chair this session, we have Dr. Mandakini Meg ma'am. So ma'am is a chairperson of ICOG Foxy 2020-21, and she's also been an international vice president for MWIA Central Asia. And we can see it's a huge CV. So of course, without wasting our time, we know ma'am as a very distinguished faculty at Foxy level. So she's chairing the session for this scientific session. So next we have Professor Tushar Kar sir. He's also a president AOGO Association of Obstetrician and Gynecologist of Orissa, and also been a chairperson and vice president of Foxy 2010, and also the chairperson of Oncology Foxy Committee, and also been published more than 50 articles in national and international journal. Welcome, sir.
Tushar is very
Next.
busy today, and I would like to hear a few words from Tushar if he is available, because he has other commitments, but he has promised to me that he will stay at least for a few minutes. Tushar, are you there?
Sir, are you there?
Not yet joined, sir.
Not yet joined. Okay, okay.
Okay,
Please
no
tell me
problem.
quick call. Okay.
Okay, sir. Yeah. Next, we have Dr. Asha Jain. So, ma'am is a director of SMSA Hospital Raipur. She's also been a medical director of Cancer Prevention and Relief Society. She is an elected member of CG Medical Council, Zonal Chair, Foxy Food, Drug and Medical Surgical Equipment Committee, West Zone, and also been an immediate past president of Raipur OBG Society and past secretary of IMA Raipur and past president. She's been highly qualified in her academic as well, and field of interest is saving the uterus, fetal medicine, OBG ultrasound, and critical care with also a preventive oncology and colposcopy. Welcome, ma'am, for today's session. So I kindly request our chairperson to introduce the faculty speaker in each session. Thank you so much.
So, good afternoon, everyone. Am I audible?
Yes, ma'am.
Yeah. So, I think it's a great pleasure to be back with the ICOG and seeing all my very favorite people, Parag, Sarita, of course, Ashish, Jaydeep, Madhuri, Sheila Mame, and so many of you, Abha Sinha, and I think Asha Jain. So thank you very much. And I think Parul has said very correctly that when he was my vice chairman, when I was a chair of the ICOG, unwillingly or forcibly, we were drawn to actually start these Zoom meetings when we were not very much aware because of the COVID. And today you see how much we are flourishing, how much we are, using this technology to upgrade the knowledge. And I think it is now become the mainstream of our scientific deliberations, our CMEs, our certificate courses. And I'm extremely happy as a past chairperson to see this growth and, wonderful, opportunity for the students, which we actually imagine. So with this, I think it's my pleasure to introduce our Ashish Mukhopadhyay. We have a long association, he has already told. And when I was the vice president, conducted so many conferences at Kolkata and all the time in the Foxy. We have a great academic partnership as well as the exchange, and on the social level also we are very good friends. So he is known as academician, principal and professor of unit chief at GND, CSS College of Obstetrics and Gynec at Kolkata. And he was the vice president of Foxy 2016-17. Governing council, I remember in the middle of the night, Ashish, you phoned me, madam, I want to contest. And I was there for you. So it is a pleasurable memory. Then past president of the Bengal OBGYN Society, ex-chairperson Medical Education Committee. He's doing a great job by conducting this master classes. Scientific chair, we all loved his all the academic feast of the last ICOG and WHO fellow. So here is the Ashish, and he is going to describe the breech presentation, though it looks so simple, but it is the vanishing art. And I think we have faced so many, I personally have faced so many after coming head in the breech, which was stuck in the vagina, and how we delivered. And it is it's a quite a interesting case history. So with this, I think, Ashish, the floor is yours. Please go ahead with your deliberation. Ashish.
Thank you, madam. Thank you so much for those kind words of introduction, and my respectful regards to all the dignitaries and also my chairpersons. So here I am going to talk on something which is really a very difficult topic, not only for the students, but also for the practicing obstetricians, and therefore it will be a mixture of talk. It is not entirely for the students, but also for the practicing obstetricians. And I'd like to give some messages, and I'd like to share my screen now. Is the screen visible to all of you?
Yes, sir.
Am I audible properly?
Yes, sir.
Okay.
Very much.
Then I will go for this. Okay. Now, there is a quote from ICOG 2020 I will begin with, and that is, because breech presentations are associated with a high rate of cesarean birth, and there is a renewed interest in techniques such as external cephalic version, ECV, and also the vaginal delivery, spontaneous vaginal delivery of the breech, which happens, and ACOG said in 2020. Remember, it is the same ACOG which gave us different ideas about breech deliveries. I'll come to that later. But in the meantime, we have understood that we are doing a huge number of cesarean sections. The sections rate is very high. I'll come to that in a short while. And another thing is that everybody is concerned about the rising rate of cesarean section. So this statement is very worthwhile. Now, the concerns in breech presentation are 3 to 4% of babies present as breech at term, and the incidence is much higher at the lower gestational age. All of us know that. Less than 28 weeks, it is 20 to 25%. At 32 weeks, it is 7 to 16%. And at term, you have seen 33 to 4% babies. And look at the cesarean section rate. In 1970s, 14% of all breech babies were delivered by cesarean section. By late 80s, the number rose to 86%. And today, almost 100% breech babies are delivered by cesarean section. And that's the concern, maybe because of the breech and rising awareness about the breech delivery. This concern was basically raised, and the rising cesarean section rate, I would say, has increased because of one important trial, which is known as the term breech trial, also known as the HANAS trial, which happened in 2000, and the ACOG recommendation, which came immediately the next year, 2001. So what was in it, the term breech trial? It was a randomized study, multicentric study. Over 2,000 women were subjected to this trial with a singleton term pregnancy with breech presentation. That's the commonest presentation of breech that we have in clinical practice. It was concluded that policy of planned cesarean section led to a significantly better direct neonatal outcome compared with a planned vaginal delivery, and that this was not associated with a greater maternal morbidity until 6 weeks after delivery. This was a landmark statement which was published in Lancet 2000, and therefore the inevitable had to follow. That is the ICOG recommendation 2001, which said that except in cases of advanced labor and imminent delivery, which are otherwise not defined, women with persistent singleton breech presentation at term should undergo a planned cesarean delivery. Now, there are black and white points here. Now, this is a landmark statement leading to a huge increase in the number of cesarean sections. Even when the patients had a history of vaginal delivery with breech in the previous pregnancy, they were subjected to some cesarean section promoted by this thing. This was published in 2001. But I would like to draw your attention to one word which I have underlined, that is the persistent singleton breech presentation. This has got a separate meaning. So that also means, I don't know whether ICOG meant that in that time or not, but persistent singleton breech means there were efforts of correction of the breech to a cephalic by a process known as the external cephalic version, but they failed, and therefore this is called the persistent singleton breech. If that is so, it is okay. But the question remains. There are some questions even after this that happens. And those questions are raised between 2000 and 2006. Is it possible to deliver all term breech pregnancies by C-section? Practically speaking, well, the mother may insist on vaginal delivery. I don't know how often that happens, but it may happen. Breech labor may be precipitate. That means everything is over when you reach there. Second fetus in twins may be breech presentation. In developing countries, cesarean facilities may not always be available everywhere. And also, breech may present, although rarely these days, late in the second stage with breech in perineum, or maybe half of the baby's trunk is out when you reach the delivery site. So these are the conditions where you need to have a vaginal delivery. You can't have a cesarean section in these situations, and therefore you must learn the art of vaginal delivery of breech. The second question is baby's well-being assured with the cesarean section? Well, RCOG in 2006, they said that breech per se, nothing else, is an independent risk factor for the neurologically impaired infant. It is associated, breech is associated with cerebral palsy, irrespective of the route of delivery, and no evidence that long-term health influenced by the route of delivery. So it said in RCOG in 2006. Third question is it justified? From looking from the mother's point of view, increased maternal morbidity and mortality, immediate excess maternal mortality risk 0.3 to 0.4 per 1,000 deliveries, and during subsequent pregnancies, you all know what happens to that woman. The repeat cesarean section rate rises to 20 to 60%, and probably even beyond that, 70, 80%. And some of us still believe that once a cesarean is always cesarean. Increased maternal risk and fetal risk, uterine rupture was there, and the most dreaded consequence is the placental invasion at the scar site and hysterectomy, so-called the placenta accreta spectrum. And this was revealed in VVAC study group in 2000. So I think that thoughts were going on at that time only. And then came the pitfalls of the term breech trial or the Hana's trial. What were the pitfalls? The selection of the women were not proper. The standard care were deficient in many cases. Women were recruited during active labor. Lack of trained attendant at the time of planned labor also happened in some cases. More number of macrosomic fetuses were recruited in the study. Many of the perinatal and neonatal deaths included in the study were not related to the mode of delivery, and 2 years follow-up of the babies showed no significant difference in the two groups. So that happened in 2006. So now the Hana's trial was put to question. And then came this trial called the Premoda trial. So Premoda trial is basically on the alternative route delivery trial. It centers in centers where planned vaginal delivery remains a widespread practice. There are many places like this in the world. And in complying with the rigorous conditions before and during labor, no significant extra risk is associated with planned vaginal delivery. And planned vaginal delivery of singleton fetuses at term remains a safe option that can be offered to women. And this was published in American Journal 2006. So where are we today now? We are at the crossroads, and we have to take the decision very judiciously. Of course, the Hana's trial, the cesarean section for all, is not the solution. we have to learn the vaginal delivery of breech. Coming to the other part of the spectrum, that means the clinical diagnosis of breech presentation. All of us know that although BMJ published a data which was the clinical accuracy sensitivity of the clinical examination 70%, but I'm sure all of you will agree that in clinical practice, our clinics for the diagnosis of breech accurately is much less, maybe 40% or 50%, something like that. So that's why the common dictum goes, don't trust palpation. It might be a fetal lie. So you need to confirm your palpation, digital palpation, with some other thing. We'll come to that later. But in clinical examination, all of us know that parabdomen, the fundal and pelvic grips are decisive. Fetal heart sound location is higher near the umbilicus. And per vaginal examination, we were taught painstakingly in our student days when the patient not in labor, how to diagnose breech palpating through the fornices, soft irregular mass, hard sectum in the frank breech. And when the patient in labor, external genitalia, feet palpable in flexed breech, Hills will identify the footling. Differentiation between foot and the head, hand and between anus and the mouth are important. So finally comes the role of imaging, and ultrasound is the only imaging that is necessary because it confirms the clinical diagnosis in 100% of cases. So an ultrasound, sooner or later, say when the patient comes to you, is an absolute necessity in case of breech presentation. You also get biometry. You decide the type of the breech. The attitude of the head is most important. Is the extension of the neck. You have to be found out typically, and you have to write a note to the radiologist that I want the condition or the position of the neck, whether it is extended or not. You may need 1 or 2 exposures more to find out whether the neck is extended or not. This is vital and crucial. This is decisive in favor of cesarean section. Placental location, we all know placenta previa to be associated with breech presentation or carnufundal attachment of the placenta. Amount of lichens can be excess, it can be less, and the Doppler study in indicated cases. X-ray is almost obsolete these days, except in examination plates. You won't find them anywhere. CT scan and MRI are not necessary for the diagnosis of breech presentation. So I think the only thing that is their need is a clinical examination sooner or later, followed by an ultrasound. The risk factors for breech, all of us know that, maternal risk factors and fetal risk factors. Maternal risk factors are previous sibling or either parent having breech presentation, uterine anomalies, placental location, amniotic fluid, nulliparity, contracted maternal pelvis, and older maternal age. Whereas the fetal risks are preterm gestation, anencephaly, hydrocephalus, sacrococcygeal teratoma, neck mass, these are the fetal anomalies. Then extended fetal legs are contributory factors, crowding from multiple gestation, fetal neurologic impairment, fetal growth restriction, asphyxia, etc., and even the female sex. More importantly, the recurrence of breech is very, very important. If you have one pregnancy with a breech, the recurrence in the next pregnancy is 9%. After 2 consecutive pregnancies, it's 25%. After 3, it is 40%. On the other hand, if the first pregnancy is not a breech, non-breech presentation, the frequency of breech presentation in the next pregnancy will be 2%. Now, this is the important differentiation which I was talking about, between the difference between face and the anus. The greater trochanterus and the anal orifice form a straight line across the buttocks, whereas the malar bones in the mouth form a triangle in the face. Now come to the management part. Now, strategies. There are different strategies of management of breech delivery, and just one by one they are. Number 1 strategy is the external cephalic version or ECV before labor with a trial of labor if the version is successful, and cesarean birth if unsuccessful. So it's simple. You try an external cephalic version at a suitable time I will describe later. Then you have a trial of labor if it is successful, and if it is not, go for the cesarean birth. So you take a decision and that becomes easier. The second strategy is external cephalic version before labor with a trial of labor. If the version is successful, that's all right. The first part is okay. However, if the version is unsuccessful, do a risk categorization. That means low risk, give a trial of labor. High risk, go for cesarean section. So it's just a segmental approach towards the breech after ECV. So but ECV is a must. Third is the planned cesarean birth for breech presentation without an attempt at ECV. I'm afraid that this tendency is going on, increasing now in clinical practice as I look around me. And I think this is unfortunate. So I think that with the irrespective of the attempt at ECV, the planned cesarean birth may increase the cesarean section rate. And fourthly, a trial of labor and vaginal breech birth in low-risk population straight away. So these are the 4 strategies that we have applied in breech presentation. And the commonest strategy is try for the external cephalic portion. If it fails, then go for C-section. If it's successful, go for the vaginal delivery. For the students, I think they may face these common causes of breech presentation. I've already explained the risk factors for breech, but in theory and in practical, you answer differently. This is a short bit about the students. In theory question, you classify your answer like this. Whereas in Viva, if you're asked this question, then you say that whatever you have seen in your clinical practice in the last 3 years of training, that means you start with prematurity, the commonest cause. Then you forget about the maternal and fetal. Types of breech, all of you know, complete breech, incomplete breech. And I don't need to elaborate on these things because all of us know that the incomplete breech has got 3 divisions: breech with extended legs, footling presentation, and knee presentation, which is very rare. And the prognosis of vaginal delivery is worse with the footling. All of us know this. The effects of on the mother and fetus, maternal health is largely unaffected in pregnancy. Perinatal morbidity and mortality is 3 to 5 times higher than cephalic, and that's the major concern. And the reasons are asphyxia, intracranial injury. These are the 2 predominant killers of the baby. And then third comes the injuries like soft tissue injury and fracture anywhere of the fetal body from toe to head, newborn body. And the nerve injury is quite infamous in breech presentation, which has been running over the years, like brachial plexus injury, OBS, and plum case pulses. So antenatal management largely consists of the routine antenatal care up till 36 weeks when we plan an external cephalic version, and then we take a decision regarding mode of delivery. Now, external cephalic version is one of the most effective procedures in modern obstetrics and is both safe and cost effective. It is other thing that nowadays the practice of external cephalic version is going down and down, maybe because of the lack of practice or lack of training. But RCAG recommends all women with breech at term to be offered external cephalic version, but only 43% consultants, according to their estimate, practice it. And I dare say in our country, it is much less also. So this is an underused option in the management of breech fetus and term. Lack of training, as I said, training of undergraduate level learning curve. So best started early. It has got a long learning curve. And there should be recognized training courses. And here is a message for ICOG, which can do its best here. And training is best in simulators. That's why simulator-based trainings are in vogue nowadays. Whatever you say, you have to remember the contraindications, risks, and cause of failure. Contraindications are antepartum hemorrhage of any form, severe preeclampsia because that may initiate convulsions, contracted pelvis, of course, no multiple pregnancy because of jammed, scarred uterus, gross anomalies of the uterus or fetus. And then there are causes of failure like frank breech with extended legs, obesity, and scanty liquor. And dangers will be, of course, accidental rupture of the membranes, leading to cord prolapse or abrupt plascenty, fetal distress or death, or fetal-maternal hemorrhage in cases of RH incompatibility and cord accidents, as I said. So these are the things that you should remember. But this apart, I think if all other cases, you must practice, or you should practice rather, external cephalic version before calling it a day for cesarean section, in favor of cesarean section. Success rate of this thing, external cephalic version is 50 to 60%. Some people claim higher. And I just mentioned in the passing about a few scoring system in breech. One is the Zatuknian and Rose, probably more studied, then Westing and breech index scoring system. So these are the scoring system, but in practical reality, I wonder how much is the utility of these scoring systems. And that's why I'm skipping them rapidly because time is limited. More important is what are the indications for the cesarean section for breech presentation. One is contracted pelvis, of course, that is an indication nobody will prevent you. Big baby within fetal weight of estimated fetal weight of 3.5 kg. Some people put it at 4 kg. But in our country and in our situations, I think 3.5 kg is a reasonable option. Hyperextended neck, as I already told you, obstetric complications like uncontrolled severe preeclampsia, gestational diabetes mellitus, severe FGR, etc. Bad obstetric history like previous IUD or early neonatal death, the lady won't dare allow or you or approve of external version. Uterine dysfunction or deformity which will prevent that, etc., etc. So now, trial of vaginal delivery, which are the cases where you would like to attempt or rather desirable, presentation should be frank or complete breech. Frank breech is a better dilator than the complete breech, but however, you can give a trial with a complete breech also. Baby weight between 1.5 to 3.0 kg, preferable, although the upper limit is 3.5. I will say 1.5 to 3 is the favorable, ideal. Pelvis, no evidence of fetal-pelvic disproportion, and here I say it with a word of caution because the head is a very good pelvimeter, which we find in cephalic presentation, but in breech, we don't get that advantage of head as a pelvimeter. So what happens that in the labor, suddenly, all of a sudden, the hard head falls into the pelvis, and that causes all of the problems and difficulties. And also, the head cannot undergo molding because it is not associated, have a prolonged association with the pelvis. And therefore, that's a practical difficulty. So you must assess the pelvis properly. And whenever there is an iota of doubt also in your mind about the adequacy of pelvis, as it is defective assessment. So you go for cesarean section. Nobody will scold you for that. No hyperextension of the neck and no medical or obstetric complications which are likely to be associated with mechanical difficulties in deliveries. Types of or methods of vaginal breech delivery are three. One is the spontaneous. It happens in 20% of cases, but we are not encouraging that anymore. Assisted breech delivery, which is also known as the partial breech extraction, which happens in 70% of cases, is the ideal. Only a series of simple manipulations with little analgesics and anesthetic requirements. There is a little scope of detailed discussion on this issue. So therefore, I would like to say that supports are required at three levels: buttocks, shoulder, and head. Breech extraction is now rarely done, but the indications of fetal distress and emergencies in labor. So I'm not going into detail of management of labor in the first stage because all of us know this. The usual things are there like IV fluid, non-ambulatory patient. You cannot allow ambulation in a malpresentation. Exclude cord prolapse, emergency C-section, the indications all of us know. In second stage of labor, as I said, the assisted breech delivery, there is no scope of detailed discussion here, like we did the other day in the student session. But here, I would like to press some mechanism of labor and breech presentation, assisted breech delivery. What are the requirements? An experienced obstetrician skilled in breech delivery is extremely important. An anesthetist at the beck and call with a full OT facilities, one or two assistants, fully equipped labor room with obstetric forceps, and the neonatologist with newborn care corner. Now, there are some do's and don'ts I'll mention in the passing about the assisted breech delivery. Careful selection of the cases for trial of labor, as I said, extremely important. Don't select the cases in a hurry. Don't go by emotional. Don't go by calculation. Don't go by statistics. But realistically assess the passage in each and every case before deciding for the vaginal delivery of the breech. That's the mool mantra. Otherwise, what will happen? You will select wrong cases and you'll put a negative message to your juniors. Augmentation, if necessary, after excluding fetopelvic disproportion. Dorsal lithotomy position, I know it is cumbersome, but lithotomy is important for breech delivery. Episiotomy, obstetrician prerogative, but recommended in most cases of breech delivery. Continuous monitoring is important by a CTG these days. And per vaginal examination as soon as membranes rupture to exclude cord prolapse. Always keep the baby's trunk or back anterior and wrap the baby in a sterile warm towel. That's extremely important. Few don'ts are: don't pull from below, always push from above. Never be in undue haste in taking out the baby, any body part of the baby. In fact, when the breech is climbing on the perineum, don't sit there, move away for a cup of tea and ask your assistant to close the vulval outlet with both hands. This is called Derek Llewellyn-Jones technique, and he used to, always push the perineum so that it encourages the flexion of all the fetal parts, including the fetal neck, fetal head, fetal body, fetal trunk, fetal legs, etc. So there is no difficulty in delivering of these things. If you are there, you're sitting over there, not having a cup of tea, then what will happen? You'll pull one leg or pull that leg and then try to pull the baby, and that will create all the problems. Ask the nursing staff to change the position if she's preferred dorsal or left lateral or other position to so far make a lithotomy. And I will not go into detail of all these areas, but I will just give you two videos of 2 minutes duration. One is the peanuts maneuver and other is the lobsters maneuver. for the delivery of the arms. I think the video will speak for itself. So at one point in time, I will just stop this lecture and I'll go for the video presentation. Please allow me that. And I think that I will go to the video now. Can you see the video now? So now we come to the delivery of the arms.
No, sir.
They said, you don't see it. I am.
Sir, you have to share the video.
Yeah, yeah. I don't know why isn't coming.
Have you shared it?
I have already shared it, but then the video.
सर फर्स्ट तो वीडियो ऑन करिए फिर Zoom पे आके शेयर करिए तो वो शेयर हो जाएगा.
Video is already on. Okay.
उसके बाद Zoom पे आइए जैसे स्क्रीन शेयर करते हैं वैसे ही आपको वीडियो वाली वीडियो दिखाई देगी.
वो स्क्रीन में नहीं दिखाई दे रहा है वही वाला. हाँ.
ट्राई.
Okay, I think that I will go once again to the back to the video, and these two videos are very important. 2 + 2, 4 minutes I'll take, and yes, I'll do it from here. Okay, yes, now you'll be able to see the video. Yes.
Yeah.
Can you see now? We come to the
Yes,
data.
sir. Yes.
As I said, I should always put the baby with the towel, but just for showing, I'm just removing it. But in practice, you should always keep the towel there. Anyhow, as I already said, feel the scapula. The importance of towel is very, very important because when you wrap the baby with the towel, it traps actually a layer of air between the fetal trunk and the towel. And that we know that air is a very bad conductor of heat. So it prevents dissipation of the heat from the fetal body, and therefore it prevents hypothermia, so very common in newborn babies. What are the scapula? If they're parallel to each other, then the arms are flexed. So then the delivery of the arms are easier. But if the middle word of the scapula is winged or making an angle, that means they are extended. So one or both the arms can be extended. For that, we need Lobstead's maneuver. The alternative mechanism is classical method, which needs general anesthesia. That is cumbersome. We are not going to show that, but we are going to show you the Lobstead's maneuver. Now, what do we do in Lobstead's maneuver? In Lobstead's maneuver, we take advantage of the fact that the anterior end of the pelvis and the posterior end of the pelvis, there are sharp difference of angulation. And whatever is above the symphysis pubis in the anterior part is, when taken backwards, it comes below the sacral promontory. So what we do, we take the advantage of this curvature. We hold the baby in femoral pelvic grid. So the hand and the anterior part is above the symphysis pubis. You rotate the trunk, baby's trunk, keeping the baby's trunk anterior and a bit lateral flexion like this. And when it's rotated to 180 degree, as you see, it comes below the sacral promontory. Okay. So similarly, when this arm, which is above the symphysis pubis, when this is taken to the back, then it comes below the sacral promontory. Now the arm below sacral promontory, when it is again rotated through 180 degree, then this arm comes below the symphysis pubis and is easily delivered. The same mechanism can be done in the opposite direction and the arms are delivered. So this is Lobstead's maneuver, which is very simple, doesn't need any anesthesia. And you are doing the manipulation, holding the baby from outside the pelvis, and therefore it is safe and quite effective. recommended legal offset for all arm deliveries, but is now only when the arms are extended. Okay, so that finishes the delivery of the arms, the extended arms, basically, which is a major problem in delivery of the breech. And now I will come to that dreaded portion of the delivery, that is the delivery of the aftercoming head of the breech. Another 2 minutes, video, I'll show you delivery of the aftercoming head of the breech. This is, yes. Can you see this? So that brings us to the delivery of the aftercoming head of the breech, which is the most crucial and the rate limiting step in the delivery of the breech. The optimal time between the delivery of the umbilicus up to the mouth is 5 to 10 minutes. 5 minutes is the lower limit, 10 minutes the upper limit, after which the chance of asphyxia, intracranial hemorrhage, all sorts of complications start increasing. There are 3 techniques to do this delivery of the aftercoming head, and they are usually done in the following succession. Like the first is we try Barn-Marshall method, then we try the Mauritius-Smelly Reed technique or the malar flexion shoulder traction, and lastly, if they all fail, Piper's forceps. Now, however, there is no random or there is no fixed order. This can be done randomly and according to obstetrician's choice. First, I would like to show you the Barn-Marshall method. When the baby is hanging by its own weight and wait for the hairline to appear. So hairline, suppose it never appears in the hairline, like for instance, the baby is barred like me, then what happens? Then you try and palpate the occiput through the suboccipital angle. So if you can easily palpate the occiput, or other words, the subocciput is visible, then this is the right time to do this next movement. Otherwise, don't try this. So hold the baby's 2 feet like this together and make a curve like this, arc like this. Put your left foot in the perineum and allowing the margins to slip over the baby's face, and then over a wide arc of a circle, along with the uterine contraction, you deliver the baby like this and place the baby in the mother's abdomen. And then you suck the nostrils and mouth of the baby immediately after delivery. But remember 2 points we noted here, that the angle of the arc has to be wide arc. Otherwise, there will be a lot of injuries to the baby, and also must wait for the hairline or the subocciput to appear. Otherwise, don't try this. In the Mauritius-Smelly Reed technique, however, it's a bit slightly more convenient, but the positioning of your hands is important. Number 1, the right hand, the leading hand of yourself, it has a specific distribution of the fingers. The middle finger touches the occiput or subocciput and presses upwards. The index finger and the thumb holds the left shoulder of the baby, and the ring finger and the little finger, they are busy with the right shoulder of the baby. Coming lower down, the 2 fingers, that means the index and the middle finger of the left hand, are on 2 malar eminences of the baby. Previously, we used to put the index finger inside the oral cavity of the baby when the baby objected, and then we shifted our fingers and put our fingers on the 2 malar eminences. And then the thumb is holding the left shoulder, and the ring finger and the little finger are holding the right shoulder. So this is the way you should hold the baby. I mean, I'm showing it outside the birth canal because I wanted you to copy this, how to hold the baby in Mauritius-Smelly Reed technique or the malar flexion shoulder traction. Now see this. Now when you are constantly palpating the occiput, you always try to push it upwards. That will maintain the flexion and help the rotation of the head like this. So you deliver the head like this and always allow the occiput to flex like this. And after it is released, and you can no longer have that feel of the occiput, then you can take it like this and then lift the baby and put the baby in the mother's side. This is how you do the delivery of the aftercoming head by the. So I think, should I skip the slide video on aftercoming head of the forceps, or should I show it? Whatever you say, because the time is running out. I'm sorry, I have taken a bit extra time, and if you allow me, then I'll show the forceps delivery after coming head of the breech. I think that is also important. So if you allow me, then I will do that.
I think
Ashish,
Ashish, you should, because very few would be going for vaginal birth of breech, but forceps, I mean, in cesarean, they are doing all cesareans in breech. So
Correct.
how to handle breech at cesarean would be very important.
Yeah. That's very important. So I will go for the delivery of the head by after coming head of the breech. Okay. So I'll share screen now. Yes. One very good alternative for the delivery of the after coming head of breech is forceps. However, we need a special forceps for the delivery of the after coming head. Piper's forceps is specifically designated for this purpose. It has got a longer blade and it doesn't have a pelvic curve. So it can go straight in a longer direction. Now, for delivery by the forceps, the assistant holds the baby like this. You can see the trunk is outside, the baby is held in a towel and lifted upward just like a hammock. I take the left blade over here, which is applied first. Left blade is held with the left hand, and then I just put my finger here like this, and then I put the left blade of the forceps like this, and the assistant holds this. Okay, show this. Again, I take the right blade, which actually goes above the left blade from below the trunk of the baby. And like this. And it will go like this. Okay. Then you lock the blade. And then you take the baby out like this in a controlled manner, guarding the perineum with the left hand, and then following the curvature of the birth canal, direction exactly same as the Mauritius Mendenhall technique. So this is how you deliver the forceps by after coming head of the breech. Many people prefer this for preterm babies also, because supposedly they protect the fetal head, but many people don't believe in that. They don't agree to this. So this is how you deliver the after coming head of the breech. I think I haven't shown many of the videos because their time is limited, and this audience is also different. I'll go back to the presentation and finish it in one conclusion slides. Okay, so we have talked about the do's and don'ts, and now we will go for the last few slides. And we have already demonstrated this and Barn Marshall technique and others technique. But there are certain training issues in breech which I feel is neglected training because not many people are practicing. And these are the levels of arrest when you go for the different management classification. In conclusion, the alarming rate of C-section that we encounter these days, with all its dreadful sequelae, necessitates a careful relook into the art of vaginal delivery of breech today, or all malpresentations for that matter. Obstetricians' inexperience in managing vaginal breech delivery has contributed to adverse outcome and is likely to increase as a result of the current change in practice. Therefore, there is a need to develop and maintain the skill to deliver breech vaginally. Proper selection of cases, as I said, is a must. External cephalic version should be practiced and taught to the PGs and maybe undergraduates also, preferably with simulators. We need a handful of number of teachers proficient in vaginal delivery of breech in order to spread the message and for imparting training. Antenatal detection of breech is very, very important because detection of breech in labor is associated with a higher maternal and fetal morbidity. Senior experienced obstetricians must be involved more and more in labor room procedures, which you don't see these days. We have to be prepared for lots and lots of CS-related complications if we don't do that, like past disorders, ruptured uterus, maternal near miss, and mortality in near future. So don't want to see these pictures in the future. Do practice and train your people with assisted vaginal delivery of bridge. Thank you very much for your patient hearing, and thank you, chairpersons, for allowing me those extra minutes. Thank you so much.
So, Asha, thank you very much for that crisp, clear message, audio, video, and I think it was very, very clear. Two things which you have mentioned, and I think I also, agree. External cephalic version. In our time, in antenatal clinics, it was routine to actually do after the selection of cases to external cephalic version. It was a routine for us. And second thing, very, very important was, our senior teachers were teaching us, as you said, senior teachers teaching us actually all the manuals which you showed in the forceps delivery. So there is a definite place for the, learning the skills of the vaginal deliveries, the breech vaginal deliveries, and also teaching the students for this. One case here I would like to just mention, Ashish, if you permit me, because in Kama Hospital, I remember in the middle of the night, I was called as a HOD, and the baby was just, hanging since 6 hours, brought from the Karjan, and every other unit people were just trying to push, pull the baby. It was breech, stillbirth. And they were waiting for the HOD's order, and yes, madam, please come and do something. All the soft, parts were swollen. And that decision which I had taken, I did the craniotomy. And the instrument for the craniotomy was used for the second puncture laparoscopy because it was too small, and that CPD was missed because the patient was referred. And I put a MTP cannula, suction cannula of 6 number, drained the little brain matter, and after 2 minutes, the head came down. So this was the case actually presented in the JJ hospital, and it was one of the rare cases where after coming delivery in the breech presentation with the craniotomy with a different kind of instrument. So that is my personal experience. So thank you, Ashish, for your
Thank you, madam.
such a wonderful presentation. Thank you. And thank you for the opportunity.
Thank you so much, sir, for such a wonderful presentation. So we have next talk, that is difficult cesarean section by Dr. Niranjan Chauhan. So I request chairperson kindly introduce the speaker.
The next speaker is, I think, Tushar is not there. I will take this privilege of introducing Dr. Niranjan Chauhan. We have a long association again with Niranjan. He is a professor and head of the unit. He is a professor and head of the unit at the LTMJ Sion Hospital, joint treasurer of Foxy, president MOGS, very popular president of MOGS. He was a member oncology committee. He has given many orations, and he was a regular visitor for our cytology clinic at Kama Hospital. Now I am the president of the National Association MWA, where he was a regular faculty. He was a member of managing committee, IG, and dean of ICOG. And
thank you, madam.
Thank you. Oh, such a big biodata. Thank you, Niranjan, and a very loving brother, I may say, in the Foxy. And welcome, Niranjan, and please deliver your talk.
Yes. So at the outset, I would like to thank Dr. Ashish Mukhopadhyay, Dr. Mandakini Meg, and Dr. Sarita Bhalerao, the secretary. And we have Dr. Parul Kotadawala as the chair of ICOG doing wonders. So today I will be talking on the topic of difficult cesarean section. Nicely, Dr. Ashish has explained about breech. So I will touch upon some aspect of that. In the middle of difficulty lies opportunity. Every time whenever we are dealing with a cesarean section or a patient who comes in emergency as a section or electively, still until and unless you open the Pandora's box, you are still in a difficult situation, what you will land up with. So always you should anticipate, see the ultrasound report, clinically examine the patient properly, what is the lie, the position, the presentation, the fetal heart sound, singleton pregnancy, multiple pregnancy, transverse lie, breech, oblique lie, do a PV examination, decide consent, everything taken, and then we go ahead for a cesarean section with all the explanation being given to the patient. To touch upon historical aspect, it is still confusing to note whether this was a law which was passed as Lex Caesarea in 715-673, where a dying mother will not get buried with the fetus in situ, and the baby had to be delivered out and buried separately from the mother, or whether the king, the Roman king, Caesar, Julius Caesar was born by this method. We are still not aware. But of course, there is a publication in 1598 of the Gullimu's book, where it was a book on midwifery, and they have introduced the term section. Thereafter, section replaced the operation. So now let's touch upon the few points which are mentioned here: difficulty in abdominal access, difficulty in uterine incision being taken because of adherent bladder, because of adhesions onto the lower uterine segment, or a previous classical cesarean section. It could be uterine anomaly, a leiomyoma, fibroid into the lower uterine segment. So your decision of entering into the uterine cavity will change. And of course, we have difficulties in fetal delivery. In each of this, we will go one by one. So as you are aware, there is a difficult abdominal access, and this has already been discussed partly by Dr. Assis. The various incisions are given. The one which we use is a Fanel steel incision, and there is also Joel Cohen based method, which is also a modified transverse incision placed exactly 3 centimeter below the line joining both the anterior superior iliac spine. And then we have a vertical incision, midline, or a paramedian incision, and of course the maillard incision, where a transverse incision is made on the rectus abdominis muscle to allow a wider access to the pelvic cavity. So when you are already dealing with such, you have to understand that if it is a previous cesarean section, you have to have the scar excision been done before you go ahead to enter the abdominal wall and further into the uterine cavity, etc. And it's very important that the alignment of the upper flap and the lower flap, when it comes together, it should be very appropriate. So you have a scratch marks which we do on the with the opposite side of the blade, so that we can think about it. And then there is a proper approximation when we have. Always remember, whatever the difficulty you have, a previous 2 LSES, 3 LSES, or any other thing which is there, you need to understand that, the peritoneum, whatever it is, the peritoneum has to be opened as high as possible. Otherwise, you will land up in a big problem, and people have opened the bladder also. So you have to understand that. Okay. So kindly be very careful when you open the abdominal cavity and the abdominal wall to enter into the abdominal cavity. Once you enter, you have type of uterine incision which are there. It could be the normal lower segment incision which you take, or a classical incision on the top of it in cases of placenta previa, placenta accreta, or a big fibroid or cancer cervix is there. And of course, we have a lower segment vertical incision also which can be taken. But mind you, it can extend into the bladder. Now, once we go through this, let's discuss about the difficult uterine incision. As I said, the difficulties in the uterine incision is because the whole of the bladder is plastered because of the previous surgery on the top. So you need to separate the bladder away gradually, removed. So you have to go from the sideways and then push the bladder away so that there is no issue about the thing. Bladder is adherent to the lower uterine segment. You have to understand that previous classical cesarean uterine anomaly and fibroid or cervical cancer. So as I said, here also you have to have the similar technique as how you open the abdominal wall. You have to open, once you enter inside, you have to see that the bladder is pushed away. All these pointers are to be kept away. People have entered the bladder also. So you have to be very careful and push it, and there is no hematuria which takes place. Mind you, check the also the catheter also, which is very important. Unfortunately, however you take the best of the precautions, it is a possibility that bladder opens and it is 0.08 to 0.94%. Do not panic. There's nothing to worry. Bladder is one of the best organ which heals. The healing is superb. You just have to just extend it, the incision, whatever it is. You can tackle that after the delivery of the baby. And if you are in a multi-centric hospital, you always can call a surgeon or a uro surgeon to tackle with it. Otherwise, it is very easy. Just close the bladder in 2 layers by 3-0 or 5-0 delayed absorbable material and just forget about it. Nothing happens. You can also have a suprapubic cystostomy being done. And for that, you require a specialized urosurgeon to be called. So always to prevent this, you have to see that the incision onto the uterine wall or to the lower uterine segment has to be 2 to 3 centimeter above the lower, the upper border of the bladder, so that you are safe. Even after the delivery, you do not enter the bladder. And in case you enter, as I said before, you have to tackle the situation. Now it's very important that the lower edge of the UV fold has to be pulled up with the forceps, and then you have to push the bladder, and then the adhesions have to be pushed, and the incision then has to be placed onto the 2 centimeter. Now this is an incision, the video which you can see. I'll just fast forward this. I'm reducing the volume. Now you can see that we have opened the UV fold on one side, the other side we have opened the UV fold. Once we enter through the center, open the scissor and direct your curve of the scissor, the blade upwards, but more onto the right hand side. And now you have got these 2 forceps which we have applied it to the lower flap of the UV fold, and then you just swipe your finger and you can just push the bladder below. I call this boating technique. I always use my fingers. My fingers are not less than scissors, so they are much better off. And you just have to push them away gradually, then slide the joints inside, and the bladder is away. You can also use mop, or you can have a gauze on a sponge holder forceps, and that's how you can also push the bladder. So bladder is pushed away. Okay, this is a very simple thing, nothing to worry about. There are adhesions, you can tackle that. And once the bladder is away, see that the incision is also put in such a way that it is 2 centimeter above the bladder upper border. Also palpate the presenting part. What is it? Breach, vertex, because that incision also will make a lot of difference. How to tackle that, a 2 higher incision onto the uterine cavity, lower uterine segment, the head will be low down and you will have difficulty in delivering the fetal head. And 2 higher up also, the shoulder will come out, anterior shoulder. So all these things you have to understand, as I said. Then previous classical cesarean scar, it is already there on the top. So in that case, you can go through the same scar, or it would be wiser to go to the lower segment operation for the reasons which are there. In cases of bicornuate uterus, in cases of both the horns, identify which horn is the pregnant horn, and then you have to have a lateral extension of the uterine incision should be watched for, because this is very common in cases of uterine anomaly. And always put a mop inside and curate out. Try to see whether there is any other abnormality. Mostly in breech or a transverse lie, you will find a small septum, partial septum there, and that will help us to identify that this was a uterine anomaly. And all the adherent membranes and the placental bits have to be removed very well in such cases also. Now, leiomyoma, it is rare condition, but yes, can be found also into the lower uterine segment, upper uterine segment, subserosal. You can tackle that after the delivery of the baby. And if it is exactly sitting onto the lower uterine segment, onto the incision sites, go above that, never go below it. Deliver the baby and through the same incision, just enucleate that fibroid and it will just come out. Okay, it's very important. However, a classical section is also advised if there is a cervical cancer. I have got 2 cases and I have done this case, and classical section also has been done. Cesarean myomectomy is very common. 20 years, 15 years back ago, people used to be very skeptical and not allow, but there are many papers which have come and you can surely perform. Just keep 2 to 3 blood ready and see that if the patient bleeds while doing a myomectomy, you need to be giving her blood. The fibroid is easily removed. Immediately start suturing the cavity and then close the uterine lower uterine segment incision. Well, I prefer following the delivery of the fetal head, and the baby of the delivery. Just before I start this, it's very important that remove out the uterus, that is eventrate the uterus out, see whether all is fine. And then I push it inside, put it inside, and then I suture in the normal environment of the abdominal cavity, the lower uterine segment. I find it much more comfortable and there is no excess of blood loss. The uterus is very well contracted and everything is fine. Now we'll go one by one. I got some videos. We will try to finish as early as possible. This is the transverse lie. So you see the back is posterior. Now here you are the back above, that is superior. And the head is in one of the flank and the buttocks is on the another flank. So this is the classic case of a transverse lie. So what you need to do is take a lower uterine segment incision and try to grasp the breech. Never try to take out the hand or the shoulder pops in, put it inside. This is what people make mistakes. Recognize the leg, feel it, go towards the sole, go towards the heel, try to feel the ankle, and then when you feel the ankle, you need to take hold of feet at the level of the ankle as a cigarette butt between the index and the middle finger and take it out. The other leg will also follow. So this is very simple. And then you twist the baby and then it comes so that the back is anterior and the rest of the baby is delivered as a breech vaginally. What you do? It's a very simple thing. But here adequate incision has to be there. Otherwise, there are extensions. The dorsosuperior, that is the backup transverse lie, may be delivered as a footling through the low transverse incision. A vertical incision into the uterus is also employed. People are quite comfortable with a vertical incision. So you decide accordingly. And the fetal membranes are intact at the time of cesarean delivery. Then you also can think of an intra-abdominal version of the fetus, but we do not practice this in modern obstetrics. This is another video of a transverse lie with an IUFD. IUFD is it causes a lot of issues, problems. So we have to be, because it takes a lot of time to deliver. Now we will just see the video. Yes, I'm coming here. This is a very old video. I apologize for the clarity, but once you have opened the uterine cavity, the lower uterine segment, you just have to open the incision. This is one of the technique where you can just open it. I call it the Narasimha technique, but you decide, kindly be gentle. I would prefer a scissor to open also, but it depends what is your choice. Either of them are fine. And then we try to go hold and get through the buttocks. Never try to remove the fetal hand. And if the fetal hand comes out, you have to be very careful. Reposit it again and try to take it out. Okay, this is a very small baby. The foot, the breech has come. Both the legs have come. And the rest of the back, the trunk and the fetal head. Okay, this is the IUFD baby, which we have delivered as a case of a transverse lie. Now, deeply impacted head. This is happening in persistent occipito posterior. It can happen in deep transverse arrest when the cervix is fully dilated, fully effaced, the membranes are absent, the station is high, it is about 0 to +1, and there is a capodan molding, and it becomes really difficult to find out where is the occiput, whether it is at 3 o'clock or 9 o'clock, or is it at 1, or is it at 7 o'clock? But whatever it is, it's a deeply engaged head. You need to deliver. The baby is alive. It usually caused because of the prolonged second stage and also in failed attempt of operative vaginal delivery. People have applied forceps vacuum. They have tried to deliver, but it doesn't come out, and they have to do an emergency LSES. So remember always that with an impacted head, there are higher chances of intracranial hemorrhage, skull fractures, neck fractures, asphyxia, and even maternal complications because of prolonged labor, PPH, etc. can occur, and or an extension or a dog ear tear into the left uterine artery, which might take a lot of time with hematoma, etc. So all these things, uterine laceration has to be dealt with. It's not only about delivering, but this complication is a hazardous complication which you can come across. So the best method is basically to push 2 fingers from the vagina with an assistant there. At the same time, you try to deliver her by putting your hand inside, and slowly it glides between the fetal head and the lower uterine segment flap and go it down. You need to remove the vacuum. So that has to be broken up, and then you just have to try to grasp it and lift it up. Never try to pull it up. You pull it, it will cause extension into the left uterine artery. Never do that. Okay, it's a very simple thing. Put your fingers inside gently. At the same time, the assistant is pushing up gradually from the vaginal end upwards, and you get a good grasp of the fetal head. Once you get a good grasp of the fetal head, lift it up, and then take it out. Always. And of course, all these things can be done also vaginally, but we have to understand that this is a section we cannot lift up abduct the mother's legs. But here, this is a very simple technique. And then we have Dr. Patwardhan's technique, a very wonderful technique also, which can be used rather than going through all these maneuvers. You can just remove the one shoulder, anterior shoulder, which comes out, the next shoulder, and then you have the fetal trunk, the breech, and the lower limbs successively, which comes out through the incision. I got a wonderful video. Just have a look at it, and you will be impressed with that. Modified Patwardhan. Here, instead of another shoulder which you remove, you take out one leg, you take side, the leg on the same side, then you go to the contralateral leg, and then you go to the contralateral arm. So this is another modified Patwardhan technique which you can do. This is how it is explained here. Here you grasp one arm, that is the one anterior shoulder, then you try to go and grasp the same side of the leg, and you go to the contralateral leg, and then you come to the opposite arm. So this is the modified Patwardhan's technique. This is the video I want to show you. Have a look here. Okay, we will just go forward, open this. This is the UV fold which has been opened. Okay, now we make an incision. Here, incision has been made onto the uterine cavity. I hope you are enjoying the video. And now I will just go back little here. Okay, here you have taken out one arm. The baby is huge, 4 kg, 3.5 to 4 kg. Another hand. Now, mind you, here the humerus can crack. Do not have any fracture here. Fundal pressure, gradually. Take out the back, the trunk, and the buttocks. Okay, push little bit, push, little bit, push. Be gentle. Don't be, yes. And see, the baby has come, it's meconium stained. Wasn't it a wonderful video? So I hope I can see you, all of you, and I'll surely join you. But this is what you can do in cases of a baby which is like, deeply impacted it. Now we'll go LSES breech delivery. I will not go in the detail because Dr. Ashish Mukhopadhyay has already touched on that. But this is similar to that of a vaginal breech extraction, which we do. And the natural range of movements are to be done. The breech delivery in this section, we'll just go to the video. Okay, wait, I'll go back. Once you have made the incision onto the lower uterine segment, yes, extend it. Extend the lower uterine segment. Yes. Yes. You can see here, go inside, go inside, go inside. Yes. That's the limb. Yes. Take it out. One limb. Take it out gradually. See, cigarette butt. Cigarette butt. Index and middle finger gradually both has come together, and then the baby tries to rotate back. No, you try to get it front, up, up. Yes, yes. You should have ideally a towel. Yes, we take a towel, grasp it so pressure. Pull it out, pull it out, pull it out. Yes. Now we come, sweep your finger onto the shoulders, anterior one shoulder. Here also be careful, do not break the humerus. This is a possibility which can occur. This is also 3.5 kg. The other shoulder is also taken out. Similarly, the posterior shoulder, which is there, rotated anteriorly. And then now we lift up and deliver the baby. Yes, like a Morris's Smiley Sweats maneuver, you can just lift it up and the fetal head comes out. Wonderful. So this is how you deliver a breech. Now, extremely low birth weight babies are really difficult also situation. You have to do cesarean section, lower uterine segment. The worst scenario is not well formed here. It is quite thick. So you're going to bleed. The operating field is going to be messy. Do not panic. Nothing to worry. Just go inside. Do the uterine incision deeper and deeper and deeper and deeper. Cut it. Atraumatic extraction of the fetus should be done as far as possible. Do not lacerate the fetus. It is very common here because of the thickened uterine wall and the baby being small. So always remember. And then you have this floating head. Now floating head is seen in polyhydramnios. Huge uterine cavity is there, and the head is not engaged. It is just floating somewhere. Sometime it is breathe, sometime it is vertex. It is all moving around, and highly vascular lower uterine segment poorly formed. In such cases, you have to steady. First of all, steady the fetus. In the longitudinal lie, preferably, and that is what has to be done. This is to be done with a lateral support. Yourself assistant gives a lateral support. Now, once you are going to deliver this baby, remember, go slowly and drain gradually. After the amniotomy, the liquor, it should drain out so that the fetal head will come down, come down, come down, and then you have to grasp it. That is the best part you have to do. And establish a proper traction. Little support from the fundal area also can be guided so that it comes towards the incision. And then, well, fundal pressure is controversial. You decide whether to give or no, but just see that the head is grasped, and then the rest of the baby can be delivered in a vertex. Well, once you have grasped the fetal head, you can use one vectis or a forceps also can be used. I have used one blade, that is vectis, and that also is a wonderful instrument to deliver. I got one video. I will show you that. Previously, Barton's forceps used to be used, which had a hinged anterior blade. I come from KM GS Medical College and Wadia. There are many cupboards there. Still, they are lying there. Big cupboards with all big forceps instruments and all traction, axis traction instruments, which are just for historical purposes. So use of forceps is one of the wonderful thing. I remember our lecturer, Dr. Nauzar Shariar, in those days, and Dr. Amar Bide used to use. And this is also one of the picture slides which has been taken where both the forceps are applied. See that you do not apply the forceps blade onto the face. It can cause injury, and it has to be here properly. See that it is properly applied. So you need to understand before you apply the occiput, inciput. Very difficult, and then you close. Now this is with one forceps. Little fundal pressure and just pull it out. Yes, and see it comes out. Okay, I will rewind and play for you again if you want. Okay, just see this. We have pushed the blade properly, but here we have used only one blade. It's not on the face, so nothing to worry about. So that is the advantage of the vectis. It will, even if it is on the other side, it will not be that much harmful, but it will not be as harmful as both the blades. Okay. Conjoint twin delivery, very rare. Thoracophagus. There could be ischiopagus. There could be craniopagus. We had one case. Unfortunately, it was not diagnosed on ultrasound. She had come from outside to deliver with us with a, somewhere around 32, 34 week size. very rare, 1 in 50,000 to 1 lakh, more common in Southeast Asia, Southwest Asia and Africa. And this is one picture which was there. Our HOD, now he is retired. It was in Dr. Nandanwar's unit. I requested him. Now this is a lower uterine segment incision being taken. And then you need to also take a inverted T-shaped incision up because it will not come out. So we have cut it upwards. You can see the scissor going upwards, straight inverted T-shaped incision. Okay. Right. Now you see both the fetal heads coming out. See this. Okay. Very rare. We sent these babies also later on to the pediatric surgery. Unfortunately, they expired after 1 month. So this is the fate of usually the conjoined twins. This baby is also very, very rare, a very rare video you can see on my YouTube channel. I have got my YouTube channel. You can search Dr. Niranjan Chavan, LSCS A to Z. It has got 1,20,000 views. You can surely see. So these are the different conjoined twins which can be there: cephalophagus, thoracophagus, omphalophagus, ischiopagus, craniopagus, etc. And the different varieties which are available and what are the incidences which is mentioned here in my slide. So elective termination is often advised if you diagnose it. Nowadays, very rarely we will find such cases, very, very rare. And then if in any time, whatever the incision you have taken or whatever the presentation, if there are uterine incision, tears while removing the head, nothing to panic. Use a green armitage or an Elysis forceps and start suturing, but see that ureter is away and the uterus is lifted on the opposite side. So this is what you have to do. You have to do interrupted sutures in that area of the tear and gradually also mop and keep it pressed so that the bleeding edges and vessels are all contracted. Okay. Now, if it has extended down running towards the bladder, you have to identify and separate the bladder away and go to the lowest point with an Elysis there and take an incision and then go upwards, continuous interlocking, mobilize the bladder. Unfortunately, in spite of all these things, if you feel that the bleeding is not controlled, then you will have to proceed with a systematic devascularization procedure. At this time, I would request you to please call your superior, senior, so that he can be a better judge to handle the situation. Always call for help. These are the injuries to the fetuses which have occurred. You can see that there is a break in the clavicle. There is also fracture of the femur, the fracture of the tibia. There is a fracture of the humerus. Unfortunately, such injuries also can occur, but you have to be very careful, medico-legally, take all the consent and do proper LSES. Okay. Atraumatic delivery is the goal of an obstetrician. Now, there are various causes of injuries, but do not be in a haste. I see my resident doctors, they are really messy LSES they do. I do not want to criticize them, but it's all bloody, it is all messy, and they use Narsima technique. Have some tissue sense. There is sixth sense and there is tissue sense, and respect the tissue. And I'll tell you, your surgery will be the best surgery and the healing process will be much faster and much better. And inappropriate and inadequate incisions can also be tackled, and try to have a good adequate incision. See the comfort of yourself rather than just going for a cosmetic incision. So be safe, be sure of what you are doing, practice, be swift. Everything is at spinal level. There is no cerebrum to be used. So be swift and suturing. Don't just go on mopping. Mopping will not solve your problem. Suturing and control of the bleeding is the most important thing. You should be very sound in your clinical and surgical skills. I always tell my resident doctors, practice whenever you do not, you have time, you are free, you practice surgical knots and tighten them properly. Okay. And do relentlessly, do bloodless. My mother used to say, and my teachers also from Sion Hospital where I come, say that obstetrician should be one who has ladies' fingers, long, slender fingers, lion's heart, jigger, lion, eagle's eye, hawk's eye. You should have be very sharp in your eyesight, and you should be very good in seeing minute bleeders and proper dissection. Good hand dexterity and Doberman suspicion. This will only come by lateral thinking. So thank you so much, ICOG Masterclass. I hope I have done a good justice. I would like to end the lecture by saying this quote by our own honorable president, the leader, the ISRO scientist, Dr. APJ Abdul Kalam. Difficulties in your life do not come to destroy you, but to help you realize your hidden potential and the power you have. Let difficulties know that you too are difficult. So thank you so much for a patient hearing, and I stop sharing now.
Thank you so much, sir. Such a wonderful and very interesting presentation. So,
I was concluding that. I
yeah,
think I was
ma'am.
not audible. Yeah. So thank you. And there is no obstetrician, Ashish and Niranjan, that who has not come across any kind of difficulties. I think we ourselves in our unit, total dome of the bladder I have seen ruptured. We only have repaired. Then we have seen many cases with the incisional hernia along with cesarean sections. There are many other cases, individual cases which are also reported. And I think everybody should learn from the masters. And I think there are many surgeons here who are known as a referred surgeon. In the district also, if there is any difficulty, they are called. Like we have Dr. Agarwal also in the Mira Bhayandar. For any difficulty, they are there. So they are doyens who are so much experienced, skilled, and they are a great support to the juniors. I think that should be the key for all the successful surgeries. So thank you, Niranjan.
Thank you.
Thank you.
Madam, if any other questions are there, I will wait. Thank you so much.
Now the
Thank
next,
you.
next
Yeah.
lecture.
So next we have the last speaker, that is pain relief in labor, will be presented by Dr. Sharika Rai. So I request our chairperson kindly introduce the next speaker, please.
Thank you, Dr. Manisha. So thank you for having me on this prestigious platform. And I would like to introduce, may I have the next CV, please?
Yeah,
Dr.
it is ready.
Sharika Roy, ma'am. She is a consultant at Shivam Hospital and Research Institute, Patna. She has done her graduation and post-graduation from JNMC, Belgaum, and has had specialist training from Bradford Hospital, UK in the year 2000. She has worked as registrar and full-time consultant. She's done more than 5,000 deliveries, including breech, twin, and forceps delivery, cesarean, amnio infusion, etc. She's done all types of vaginal and abdominal gynec surgeries and lap surgeries. She has a great interest in vaginal deliveries, management of high-risk deliveries, and recurrent pregnancy loss. She has many paper presentations, and I think this topic, labor, decreasing the pain in labor. Many women these days, the high class ones are very afraid of the pain. They don't even want to be examined. And if somehow we can eliminate the pain, then definitely the chances of normal delivery would increase. So let us all learn today from Dr. Sharika Roy how to obtain pain relief in labor.
Dr. Sharika Roy.
She's not here.
Hello.
Yes.
Yes, ma'am, we can hear you. Would you please share your screen?
Good evening, everyone. I'm not Dr. Sharika Roy. I'm Dr. Tanisha.
Yes.
Hello. Am I audible?
Yes, Dr. Tanisha.
Ma'am, sorry to say that ma'am is in an emergency OT. Ma'am said she will join me, but she has asked me to start her PPT till she comes back from the OT. Hello, ma'am.
Hello. Yes, I think
ma'am,
Dr.
I'm Dr.
Tanisha.
Tanisha. I am ICOG Reproductive Medicine Fellow of ma'am, Dr. Sharika ma'am. Ma'am is an emergency OT. Till then, ma'am had sent me her PPT and she has asked me to start the presentation and she will come back for the demonstration.
Okay, I think chairperson, is there any, I think she can continue with the presentation.
Yeah, I don't think there should be a problem. I don't know what the
Panel
ICOG
first and
guidelines are,
then
but
the
they should be
lecture.
fine.
So
Yes, Dr. Parag?
No, we'll take the panel first and then the lecture. It's not.
Okay, sir.
okay, okay,
Okay,
okay, sir. So sorry for this inconvenience. I think Dr. Sarika will be presenting later once she is available. So moving with the next session. So I think thank you so much, Chairperson Dr. Asha Jain and Mandakini ma'am. But I think we'll be calling you again for chairing the session for Dr. Sarika Rai presentation. So moving with the next session, and that is a session on panel discussion on induction of labor. To moderate this session, we have Dr. Mitra Saxena. So, ma'am is a chairperson in the Practical Obstetric Committee FOXY 2021 to 2024, and she is also a convener FOXY GCPR on birth after cesarean section, member FOXY for GCPR Ectopic 2020, and she is also a member of many societies and awards in her name. And her area of interest is high risk obstetric, ultrasound, endoscopy, infertility, colposcopy, and contraception. Welcome, ma'am. And we have expert for this session, Dr. Ranjana Khanna, ma'am. Ma'am is a ICOG Governing Council member 2021-25. She's also the founder president of ISOPUB, Pragya Raj 2021-25, and executive member of National ISOPUB 2023-25. She's the president of AOGS Allahabad and organizing chairperson for National FOXY Conference. She has many national awards as well and also faculty at national and international level. So welcome, ma'am, for this panel discussion. So I kindly request our moderator to introduce her panelist.
Thank you so much, Dr. Manisha. Am I audible and visible?
Yes, ma'am.
So, welcome, Dr. Ranjana, the expert for our panel today. Well, actually, I'm not going to look at the CVs of our panelists because I know them all personally. We all know Dr. Sarita Balerao is a very, very good obstetrician, and she's also the secretary of ICOG. Dr. Abharani Sinha, madam has been with me for the last 3 years. She has been my committee member and my advisor, and extremely busy in her role as a professor and HOD of SKMC Muzaffarpur. And she has a vast knowledge. So I'm not going to read all the things because, we have very limited time. Welcome, Dr. Abha. Then Dr. Reena Wani, also known to me so personally and very, fantastic obstetrician, very busy practitioner. And we all know all of them are, star obstetricians. And I'm at the happy end of questioning them. We have Dr. Durga Shankar Das. Sir is a governing council member and also very friendly and has been in FOXY for the last 20 years. We have Dr. Shobha and Goody, another personal friend, very knowledgeable. She has just recently completed her tenure as the chairperson of Family Welfare Committee, and I have known Dr. Shobha Goody as well. So just let me check if all my panelists are there and give me the rights to share the screen. Please, me welcome all.
You can share it, ma'am.
So,
yeah,
I'm a bit scared today because till the last minute, I've not been able to complete my PPT. So let's see how it goes. Is it visible?
Yes, ma'am.
Yes, it's visible.
Okay, also, please let me know. Yeah. So friends, I'm going to moderate a session on induction of labor. We're going to be discussing only the practical points. And today is the ICOG Masterclass on labor and delivery. And thank you, Dr. Ashish Mukhopadhyay, to think about me and give me this responsibility to review. And the beauty of doing anything is that you yourself learn something. So today I've also picked up some nice nuggets from my practice. I'm happy to share that all my esteemed panelists are very, very good obstetricians. So welcome all of you. And now we all know that Turnbull, who's the author of a textbook of obstetrics, he has written that spontaneous onset of labor is a robust and effective mechanism and should be given every opportunity to operate on its own. We should only induce labor when we are sure that we obstetricians can do better. And today, what we are going to be talking is that the problems are solved not by giving new information, but by arranging what we have known since long. So all of us know what is induction of labor. It is artificial stimulation of uterine contractions before the onset of spontaneous labor. And this could be in an indicated pregnancy where there is a high risk, or it could be in an unindicated like we are going to discuss that part later, but that is what it is all going to come to. Augmentation, we have to understand, it is just enhancing the spontaneous contractions which are already there. So this clarification has to be there, which is very, very important for all practicing obstetricians, the difference between induction and augmentation. I'm going to be trying to cover up all these things in my panel today. So can I ask Dr. Abha or Reena that whatever is the current incidence which has been reported by US, and it has tripled in the last couple of years, it's very different from different countries. What is, and basically we don't have very robust recent global data. So both of you are in government hospitals. So do you have any personal incidents in your hospital, Dr. Abha, Dr. Reena? Any number, whichever is there, please come out with that.
I think, Dr. Mitra, thank you for asking this question. And at the outset, I would like to thank Dr. Ashish Mukhopadhyay and the whole team of ICOG, Secretary Dr. Sarita Bhalerao, and Chair, of course, Dr. Parul and Dr. Parag and Dr. Sheila. And I would like to say that because ours is a tertiary hospital, so we get high-risk cases. So the incidence of induction, I may say it is around 15 to 20%.
Okay, good. That's it. That's quite acceptable. And Dr. Reena, are you there? What is the incidence in your hospital? I think, I don't know, maybe if Dr. Reena has logged in or not. Dr. Manisha, you can check out. Never mind. We have an incidence of induction which is increasing. Why the incidence is increasing? Will anybody in the panel like to answer this question? That firstly, is the incidence of induction increasing? And if it is, then what is the reason? Dr. Shobha, are you there?
Yeah, of course I'm there.
Dr. Shobha?
Mitra ji, I'm very much here.
Dr. Shobha, I can't hear you.
Answer. Okay, really? Can you hear me now?
Yeah. मैं webinar में हूँ, बाद में बात करती हूँ.
Now we can.
Can you hear me now?
Yes.
Yeah.
Why is the incidence increasing?
Yeah, it is increasing. Actually, in some centers, it is up to 30% also, 35% also. In our own hospital, it's around 25 to 30%. So the thing is, there is an overwhelming evidence of late that induction of 39 weeks, even in low risk gravida, brings down the incidence of stillbirth. That might be one
you are very
factor for the increased incidence. Yeah, the other reasons might be in general, the higher incidence of non-communicable diseases or obstetric high-risk factors. In particular, diabetes mellitus is becoming very common during pregnancy. So I think these are some of the driving factors. And let us not forget the ART pregnancies which are there.
But in ART, do you think that they have inductions? They have more of cesarean section?
More of CS.
They have more of
they
CS.
have, but yes, there is a clinical setting for induction there also.
Yeah.
There
So,
also.
okay. And you would
there
like
is-
to say that
there is-
our obstetricians are doing a little bit of cheating for financial gain and convenience, that the induction has increased?
I am always on the side of obstetricians. I am always on the side of obstetricians.
Good, good.
I don't
Okay,
think
so that's enough.
In today's era, anybody would risk, for petty financial gain.
So we will come to elective
outcome of
induction.
mother, especially, yeah.
You
I
know,
don't think
basically,
people can
I
risk
feel,
that.
Mitra, that it is because of the increasing age at marriage. And because of that, you have more of diabetes, more of hypertension. So you end up inducing labor. So it's the
Okay, so
basic
there are many
culprit is the increasing age of marriage.
Yeah. I mean, like, my main focus would be that because, now we are very clear about the gestational age. So we are very confident that we are not inducing iatrogenic prematurity. Secondly, we have fantastic cervical ripening agents. And like Dr. Shobha has very rightly said that the elective indications are increasing, and we're going to come to that later. So definitely the induction is increasing, and so many things as pointed out by Dr. Ranjana and Dr. Shobha, we are with you that the increasing NCDs, all high risks are increasing. So we have to induce labor if we don't want them to go in for cesarean section timely. Now, basically, some basic terms. Induction of labor is artificial initiation of contractions in a pregnant woman who is not in labor to help her achieve a vaginal birth within 24 to 48 hours. This is our primary aim. We don't want to induce a labor ending up into a cesarean section. Let's be very clear on that. And in our today's panel, with the knowledge of our obstetricians, we'll try and, arrive at some consensus so that we are able to do successful induction, successful delivery, and also, especially we'll be talking about elective inductions. I'll come to that later. Now, some important terms which every person who is inducing has to know: what is hypertonus and tachystesia and amniotomy. These are terms which we should not forget. Hypertonus means that the contraction lasts for a longer time. 120 seconds means 2 minutes, enough time for causing changes in the fetal heart. Then tachystesia is when there are more than 5 contractions in 10 minutes. Again, the time for recovery is less. So these are all very important, because whenever you are using a ripening agent or a inducing agent or oxytocin, these things can all happen. So of course, we know what is amniotomy. Now, when we say that there is successful, we've already said that success means that we are able to deliver the patient vaginally after induction of labor. Now, Dr. Sarita, are you there? Would you like to take this question of addressing failed induction of labor, which is really difficult? Dr. Sarita? Dr. Sarita has joined?
Yeah, I'm here. I'm here, very much
Okay,
here.
so basically, I'm
Yeah.
giving you a very tough situation to deal with, and that is failed induction of labor. When should we say that this is failed induction of labor? And
So,
please sort it out for us.
So there are two things. Either with failed induction of labor is the failure for the patient to go in labor, that is to achieve regular uterine contractions, as you have said, after cervical ripening, or according to RCOG, insertion of 3 intracervical gels. But now everybody has different policies and different things, so we don't all use the same thing. So this is a very good guideline that they have given. But most of us, I think that after 8-10 hours, if there is absolutely no signs of labor, we may call it a failed induction of labor.
So definitely, as you've said, I would just like to add, because there's such a lot of confusion. RCOG says something, then American College says something. But what is really important to understand is no change in the cervical Bishop score. Dr. Ranjana, would you like to add your bit as well?
Yeah, actually, RCOG is of opinion that maximum you can give 2, and then the exact location where to give the intracervical gel. Should it be inserted just inside the, before the internal loss?
And that is understood, that the practice is going to be same. But I'm just saying, addressing failed. How many times will you do something for a ripening agent? And
I think maximum, when you have achieved the maximum concentration after a good Bishop score, if you have achieved, if either you don't achieve that Bishop score, the adequate Bishop score, that is 6 for primary and 6 for a multi and 8 for a primary. Otherwise, if you don't achieve a proper Bishop score and the contractions also don't come on, even after you have stepped up the dose of oxytocin, then it's better to call it a failed induction of labor.
So we will come to that. You're quite, there almost. We will be when we discuss the, I cannot make out.
Can I say something?
Yeah, please do, Shobha.
Yeah. So I think both the speakers have kind of concurred on one point, and you have also said, unfortunately, there are no clear definitions, no clear guidelines for us to go by when it comes for failure of induction of labor.
Exactly. That is
No
the
authority
confusing
has
gray zone.
exactly told. So probably what we must look at is a very individualized approach and have a very good safety margin for the mother and baby, and very importantly the family and the patient should be concurring with our decisions to go further or to stop and then do cesarean. So I just wanted to bring out here one thing, that failed induction at one instance need not always mean a cesarean section.
Very
Yeah,
right,
If
very right.
everything
of
is
course.
We
going
will
well,
come to this.
yeah, we
Dr.
can just
Shobha is
wait
actually,
for
I don't
some
know,
time
are
and
you
then do it.
Antaryami?
Yeah.
You have spoken my slide, which is going to come in a couple of
Yes,
minutes.
yes.
Very
Yeah,
good
there is
inputs.
just one
Thank
more
you.
thing of
Yeah.
personal experience of our institution experience that I wanted to add.
Yeah.
Is when we did our Robson's audit about a couple of years back, we found that the maximum incidence was for the failed induction group, right?
Yes.
That is where we could bring about some change. And after that, what we have done is, as a matter of policy, we have started trying 2 agents for ripening of cervix instead of 1. Currently, to give a very small detail, because a lot can be spoken about these 2 methods, what we have done in the past 2 years. Currently, what we are doing is we are combining mechanical method and dinoprostone.
Okay, Dr.
type.
Shobha,
So,
Dr. Shobha,
Foley's
just wait.
catheter
Just
followed
wait.
by
Just
gel.
wait.
It is giving a better
Wait.
result. Okay.
No, I'm going to come to that. Shobha, I'm going to come to that. We are going to discuss all the methods in detail and individual way you people do it. Don't worry. You are going to get your time with what you are doing for sure. So right now, what I really wanted to bring out is that the failed induction is like absolutely a gray zone. What may be okay for somebody who they have counseled, it may not be okay for the others. But as Dr. Shobha has very rightly said, failed induction does not mean a cesarean section, and we'll come to that later. Now, there are, as defined by WHO, there are some general principles about induction of labor. Ideally, induction of labor is to be done when there is a medical indication where the expected benefits outweighs potential harm. And it has to be given, importance has also to be given to the wishes and preferences of each woman, with emphasis being placed on the cervical status, specific method of induction, and associated conditions such as parity and rupture of membrane. So basically, it's induction of labor is to be, the patient, the family, the expectations, and the obstetricians, it all has to be a group discussion. Now, I would like Dr. Ranjana to please give her idea about what is the caution that has to be, taken when induction of labor is going to be performed.
Yeah, we have to be very sure about whether the indications why we are doing the induction of labor, and whether there are any contraindications to the induction. Like we have to see the pelvis, whether it's all right.
more detail अभी मत बताओ, अभी आप सिर्फ salient point बताओ, otherwise तो हमें वो repetition होगा.
So then you have to be sure that there are no contraindications for the induction, and the patient has to be explained all the procedures. Patient has to be taken into the confidence. The relatives have to be told about the procedure, and only if they agree and all the conditions are good, then only we go ahead with the induction of labor. And induction of labor should be done, of course, with a good cervix.
No, ma'am, I would like you to convey to the audience that a place which does not have facility for immediate
Of course,
section,
induction
should
of
they
labor should
induce or
never
not?
be
Because
done.
there are
Say in
people.
a primary health center, it should never be done. It
No,
should
not
always...
primary health center, but there are smaller setups in hospitals. They don't have access to anesthetists. They don't have access to a,
it should
surgeon.
always be done in a place where there is facility for emergency cesarean section.
Exactly. And important thing is that a patient who has been induced should never be left alone.
Yes.
Okay, thank you so much for bringing in these important points. Now this question is open to all. One panelist, one question. This is a debate. So setting for induction of labor, all patients should be admitted for induction of labor in a health facility having facilities for cesarean section and management of complications. Yes or no? Everybody yes? Everybody yes? Good, great. And what about outpatient ripening? Any takers for that?
No, better to do it inpatient.
No, inpatient.
What about you, Dr. Reena? What about you, Dr. Sarita?
No
So
outpatient.
no, I do understand a lot has been spoken about this, and in the Western countries they are doing outpatient ripening. But I think, as you all said, in our situation there are certain risks, and what I would do is explain to the patient that there are certain risks, and careful monitoring is necessary, and therefore we are recommending inpatient induction.
Very good. And would you like Dr. Ranjana and Dr. Shobha had pointed out, would you like to explain them that this is going to take time? Because, you know, in our side of the country, people have this concept कि अगर दर्द शुरू कराए तो फटाफट से deliver हो जाएगा. What would be your message to the
But
audience?
maximum, we can do one thing in the OPD. We can do sweeping of the membranes. That's it.
Yes, we'll come to that. Very good. So
That we can do.
outpatient ripening, very nice. And also I've seen a lot of obstetricians giving misoprostol, you know, for the
No,
patient
that
to
I
take
won't
in the
give.
evening and come back in the morning because
But
it's
while doing a per vaginal examination, just do a sweeping and let her go
So
home.
that is an experienced obstetrician at work. Thank you so much. So now about continuous electronic fetal monitoring, intermittent auscultation, and a midwife or a nursing assistant all the time. What would be the opinion of our panelists? All, yes or no? What is
intermittent auscultation if facilities are not available for continuous electronic fetal monitoring? But better if we are inducing the patient, we have a continuous fetal monitoring at least till she goes into active labor.
And once she has oxytocin, I think you would want to do that.
Definitely.
Not with ripening, we don't need continuous electronic.
Once she's in active stage of labor, we need to have continuous fetal monitoring.
Yeah. So all in unison. Thank you so much. And what is the role of partogram? So those
It has to be plotted.
Yes.
It has to be plotted.
Yes.
Okay,
In all cases, we have to monitor the progress of labor with a partogram. In all cases.
So very nice. मतलब हम लोग जो single वाले होते हैं, we are doing a little bit of cheating because we are doing the mental partogram more than the documenting it. But those who are in the institution, definitely they have a lot of workload. So it would be better that all the labors are documented and there is a partogram which is, you know,
मित्रा जी,
maintained.
एक बात कहना चाहूंगी.
हाँ, please
I
जरूर
would like
बोलिए.
to say, yeah. So we of late we have started using labor care guidelines,
Okay.
the LCG. And we
But do
have
you
found
think,
that
Dr.
it is
Shobha,
extremely
in
useful.
labor care guide, how the induced labor and the natural labor, is there any difference in your experience?
Yeah, there is difference. There is difference because LCG was primarily meant for low risk gravida, and
Okay.
unfortunately, induction of labor kind of removes that. I mean, automatically the woman gets into the zone of a little at risk labor when we induce. That is why many of us fear induction. But
So
then,
that's
we have tried LCG for induced labor, and we have found that it works just like the low risk labor.
in
So we have
fact,
found it very useful. In fact,
I'm very, very happy and appreciative of the fact that Dr. Shobha, you brought this out, because in my own mind space, I was thinking that in an induced labor, we really can't sit over a patient. We really have to have definitive changes in the cervical effacement, dilatation from latent phase to active phase. And once she's in active phase, it has to be limited over ska match. You know, in a spontaneous labor, you still know that the labor will be less painful. In induced labor, there will be more pain, and you cannot, let the patient follow a very protracted partogram. That's it. That is what I think it should be in induced labors, right? Anybody having any other opinion? Otherwise, we should go ahead.
But LCG gets implemented only after the woman enters into active labor, just like the WHO.
So it's a limited
After that,
over
the course
match.
of labor will be very much driven. It is auto-driven like. It's not very different from spontaneous and induced.
Okay, so Dr. Sarita, what would be the important prerequisites and pre-induction assessment? So how do you do it in your patients?
Yeah. So of course, the consent is very important. I'll rule out any factors which are contraindications to normal delivery, such as the position of the baby, etc. Then we would like to see the gestational age, presentation, all that. We should have a good non-stress test or monitoring, and pelvic assessment. Of course, clinical pelvic assessment I think is quite all right and quite fine.
So here again, I will ask one more question. How
Yes.
many of us are doing, like in our post-graduation days, we used to do a pelvic assessment for the primies. Now, what is your preferred time to do a pelvic assessment? Do you do it or you don't, or you just do per abdomen and you wait for the patient to come into spontaneous?
To be very frank, Dr. Mitra, if the head is engaged, then
Yeah.
usually we don't go for a pelvic assessment because that almost proves that the brim is adequate.
Very
But if the head is high, then we go for a pelvic assessment, especially if we are planning induction.
So I think that is a very nice answer from a very experienced teacher, and just very simple points to, always remember. Engaged head rules out the need for an assessment. A free head definitely calls for an induction. And I am sure everybody of us is opportunistic, or agar, as Dr. Ranjana said, कि जब भी pelvic assessment करते हैं तो cervix को जरूर देख लेते हैं. Although, the guidelines say that you should not be tampering with the cervix, yet, we do make a complete assessment of the station.
But Dr. Mitra, can I make one small point in prerequisites and pre-induction? I think we should definitely make a note of the placental position, because placenta previa is one of the very important contraindication for going for induction of labor. So one should not miss the placental position. I think that is important.
We will come to that because
But in a primary, I would still want to assess the pelvis, even if the head is engaged, because I would like to see the ischial spines and the outlet also of the pelvis.
Okay. No problems. No actually debate, but yeah.
In a primary.
Sorry, I'm so sorry.
I would always want to assess.
Yeah. So we all know about the Bishop score, and what is your personal good score and poor score? So for primies and multis, as actually Dr. Ranjana has already addressed this, question. So if a good score is there, we know that we will be successful in the induction. If the score is poor, we know that the failure will be high. And of course, our aim of using a ripening agent is to convert that unfavorable Bishop score into a favorable one and add on another agent, whatever. So Dr. Reena is not there, I think so. Anybody else would like to address this question? This is very interesting. From an obstetrician standpoint, what are the non-cervical factors associated with the higher chance of successful induction? वो कौन से मरीज हैं जिनमें हमें पता है कि she will deliver normally after our induction? Of course,
I think baby size is very important.
What?
Baby size.
Very good.
Multipara.
Multipara, yes, of course.
Sarita, please tell that.
Yeah, so I think one thing is if it's a smaller baby, not a very big baby, head is engaged. Of course, if she's multipara and ruptured membranes, then it's much easier. And and any other comorbidities, because they less risk of fetal distress.
Yeah. So I think this is really important.
A tall patient.
Yeah.
A tall patient and one who is not obese.
Yeah, low. So everything we know, these are the patients who will deliver after our induction, provided they will have.
I think the age of the patient is also important. Younger women, they have more chances for successful induction.
Right.
Rather than those.
Mitra, I just wanted to add here.
Yeah,
Mitra
please.
ji, I wanted to add here.
Please.
Non-cervical factors. I agree with Abhaji. Absolutely, age is important, and the other thing is the positivity or the mindset or the attitude of the woman.
Yeah,
how keen
that is
she
good.
is for vaginal birth.
Yeah, is she,
Because,
wanting
she will
actually to
tolerate
take
pain
over the
better.
labor pains?
Yeah, and she will not get demoralized. Okay, that is one
Yeah,
thing.
good.
One more thing which I have found is women who have some kind of soft tissue dystocia. The cervix is only part of the soft tissue. All right. So even if the pelvis is adequate, apart from obesity, the fat, occupying there can be some muscular resistance, something which keeps the head from descending well. And in
Yeah,
such
so
women,
actually
keeping
that will
them
be a
ambulant will really
Shobha,
help.
I agree
Yeah.
with you. That would be more of a difficult trial and all that, and dystocia and the soft tissue obstruction, that is different.
See, because
But,
induction, yeah. Okay.
But birth companion will also help, Dr. Mitra. Presence of a
okay.
birth companion. I think that is also one of the important factor.
That is why our LCT is succeeding because of that, Abhaji. Because
Pain
birth
relief and
companion is
birth
also vital
companion,
part
I
of
think
LCT.
both of them are part of LCT. Yeah.
Okay, so this
Dr. Mitra,
slide
we
I'm
have
just
10
giving.
minutes. We have 10 minutes.
Yeah, so that's why I'm
Yeah.
going to give this slide a miss. These are all the indications, indicated inductions. And importance is that it's not just uncomplicated pregnancies. We are going to come to the ARRIVE trial very soon. But all these patients can be induced and successfully delivered. Only thing is that severe hypertension, eclampsia, IUGR, there is an RH isoimmunization, chorioamnionitis, where fetus is compromised. We may not be able to give a very, very prolonged trial, or we may have to go up for cesarean, but all the others on the left side could very well be induced and delivered successfully. And so contraindications already, Dr. Anjana, would you quickly say, because we have to go ahead with the ARRIVE trial, I want to go on that.
Yeah, mostly any contraindication to a normal delivery would be a contraindication for induction. And of course, if we have a prior classical incision, then if there is a history of uterine rupture, there is no chance of actually inducing. And then even if it's carcinoma cervix, and then it is herpes, or of course cord prolapse, low placenta, low-lying placenta, all these are contraindications.
Yeah, so whatever is not an indication of vaginal birth is a contraindication. That's very nice. Now let's go on to Shobha. You've already actually covered a bit of it. So what we were, when we talk, I could have taken just the elective induction of labor, but I thought I will take up everything. So elective induction is not just called elective induction. It is done in low-risk patients at 39 weeks, and it's now rephrased as risk-reducing induction. So this is actually come out after a good study on 6,100 nulliparous primary patients. So tell us, of course, we have to not forget this, that the lesser the indication, greater can be the complication. So let's not forget the Murphy's Law. And whenever we choose a patient, we have to be very, very clear about the gestational age, because this quite clearly says, tell me something, please share, open to anybody, tell about the ARRIVE trial, which is the reason why people have started inducing after 39 weeks in low risk primates. Dr. Shobha or Dr. Sarita, anybody?
Yeah, I think this was something, which was slightly shocking when it came out, because we were, before all this, I think 2 years back, we were all focusing on taking our women to 40 weeks and 40 plus 2, 40 plus 3. In fact, we used to feel proud that we have taken to 40 plus 4 and there was no meconium when the baby delivered. Whatever, we used to feel that induction as well as spontaneous labor chances, etc., all will be better. And then, as is wont to happen, there was some incidence of stillbirth, maybe related, maybe unrelated, unexplained stillbirth, not even a diabetic, etc. And that set us thinking that why not we start at 39 weeks. So by and large, this practice has not resulted in an increase in cesarean section rate, which was my principal worry. So 39 plus, but of course, if suppose the Bishop score is very unfavorable, then we actually don't. We again wait for a few more days. But if we find a Bishop score of 4 to 5, or 4 to 5 at 39 weeks, then I think it gives us courage to induce. And this applies for both primaries and multis, and the high risk
Low risk
situations
patients,
as
yeah.
well, where we can wait till 39.
So actually, basically, what in Indian milieu, patients are very anxious. I think, I don't know about down south, but in north, they're very anxious. from 37 weeks only they have this concept ki ab to
Yeah,
time
very
pura ho
right.
gaya and they
Even in
want
the
to be
South, yeah.
delivered. So anyhow, it is a really tedious task to pull them till 39 weeks. But then after 39 weeks and then going up to 40 and 41 weeks becomes really difficult in private setup. You know, when it is a government setup where there are a lot of patients, then you have the security of plenty of patients and plenty of
Good
doctors.
afternoon, Mitra. Sorry, this is Reena.
Yeah.
I've just been unmuted. Sorry, because of the political rallies, I got held up in traffic.
Oh, we
I
missed
wanted
you,
to
Dr.
add,
Reena. There were a lot of questions for you.
yes, no,
Nevertheless, so you
I
are in a government setup. So please talk to us about Arrive trial. Are you doing it in your setup, in your
to be
hospital?
honest, this 41 weeks does not hold for a lot of Indian patients. And we have
Exactly.
found adverse perinatal outcomes. So even though I am at a government hospital, in fact, this last emergency, we had 12 cesareans, of which 3 or 4 were inductions. For example, there are many indications like intrahepatic cholestasis of
Yeah,
pregnancy,
we
severe
yeah.
preeclampsia, gestational diabetes who has reached 39 weeks. And there's the choice between having, immature baby and this. So although foreign studies have said 41 weeks and the ACOG guidelines are very rigid about it. In fact, my own niece is in the US and they refused to do anything until she reached 41 weeks.
Yeah.
So, but for our Indian scenario, I think we have to use our clinical judgment. Like, for example, in ultrasound, our babies have different parameters. I think we need to come out with more Indian studies, and ICOG being a leader in this, I'm sure Dr. Sarita and our team, ICOG, will come out with some guidelines. But I
think you're very right. And ICOG and Foxy, whoever, like in our country, we should have our own data. And I agree with all of you that it's very difficult to pull the patient from 39 to 40. And in 40 weeks, I've seen a lot of patients, even if I'm inducing them, you do an ARM, everything is fine. The meconium will be there. It's a sign of maturity. But patients do not understand. And once they are told that the patient has passed meconium, they are not ready to wait. So, it becomes a very difficult thing to sort out in our country.
But
So
but Mitra, I've seen in my practice that several times the patient comes at 41, 42 weeks in labor and delivers comfortably.
Yeah, that is there. If she's been so good, so well optimized, then it's good. But now let's come on to the choice of ripening agents to our panelists. What is your choice? Do you induce or do expectant management in low risk patients? At what gestational age would you induce, and what is the ripening agent of your choice? So quickly, only one line answer. Otherwise, we will not be able to finish the panel. So over to you, Dr. Ranjana. Just choose one, or you are using all. You've already said कि 41 हफ्ते पे तो deliver हो ही जाती है. But suppose you had to do induction, what gestational age and what is ripening agent? You can take non-indicated as well as indicated. What's the
Depends
choice?
on the depends on the cervix. If the cervix is unripe, then cerviprime, yes. But though now Propes is also available, and that seems more convenient.
No, have you used Profess? I know it is there, but have you used?
I have used only in one patient.
I would like to say here that, Mitra, I have done a trial with ethics approval in our hospital, and Propes we have used in more than 75 patients.
That's
it is very comfortable. It
Very
has a good
comfortable.
outcome. The only thing is we have to have a freezer to keep it. If you do not maintain it in the cold chain in the freezer, it will not work. So even as we also say for the PGE2 gel, to be honest, before Propes was available, I used to routinely use PGE2 gel because misoprostol, as per the BMC guidelines, has been made not acceptable in our BMC setup because there were a few ruptures of the uterus because of wrong dosage being used. So then we got a fatwa from the maternal death review community that no misoprostol. But having said that,
so we have 3 survey primes. Dr.
Yes.
Ranjana, myself, Dr. Reena on the survey prime.
Yeah, we are also using dinoproston gel.
Okay.
Yes.
What about
That is
you, Dr.
comfortable.
Shobha?
But with Propes, I think it's better because we can take it out if there is some problem to the patient. With cerviprime gel, once it goes in, it goes in.
Sorry, Dr. Ranjana Khanna, Dr. Mitra Saxena, and Dr. Panelists. All the panelists, I know it's a very heartening to welcome Reena Wani, who has arrived in the field to discuss on the Arrive trial. But then the problem is that we don't have any time anymore.
Sir,
So
please,
finish
10 minutes
together.
to DJ. We have
I
waited
will
for
just
so
answer
long.
this
You
question,
cannot stop
Mitra.
us. Yeah.
Can I answer this question?
Now,
No, sir,
we have
no more
reduced
time.
labor
Please
Can I
finish it.
answer this
Madam, please
question?
finish it.
Mitra,
Pardon?
can
Yeah.
I answer the question?
Yeah.
Yeah. So in our hospital, as just like Reena said, we also had a trial for Propres versus Dinoproston.
Okay,
And
so
that
okay,
was a thesis by
Profess,
one of
and
our
that's it.
students. We
What about you, Sarita?
found that Dinoproston.
So I think all these are good methods, but my personal choice is oral misoprostol.
Okay, so
I
think
think
that
that
is
is
wanted.
extremely
One word
convenient in my
answer.
setup because you don't, and I give 125 micrograms every 3 to 4 hours up to a maximum of 3 or 4 or 5.
Okay, at what
Provided
frequency?
she's not previous cesarean, she doesn't have to be a previous cesarean.
If she's previous cesarean, I'm not inducing. I don't induce.
I'm basically giving it only in primies. Misoprostol, I give only in primies.
Ma'am, just 1 second. Please understand. I just want one answer. So I have the votes, maximum votes has come to Survey Prime. And Misoprost, Dr. Sarita is using. Very good. There are a lot of.
I'm also using, but in
I have to
primies.
say something.
Yeah.
Can I say something?
And
Dr.
Propes
Mitra,
also.
my
Keep it
answer
short,
was
otherwise
not
I won't be
valid.
able to ask you more questions.
Yes, I am short. I am sure. The Dinoproston pessary which we used, we saw that there was higher incidence of meconium with that, and the pain perceived by the woman was much higher than Dinoproston. But it was more effective. It was more effective.
Yes.
Now, misoprostol has a particular application when there is premature rupture of membranes before labor, and also more in primies rather than in multis. So we do a slight fine tuning, but overwhelmingly what I wanted to state today is that we should not give up if there is no response with one method.
Yeah.
Maybe we should go for combination of a mechanical method and a pharmacological. So currently we are with Foley's catheter induction followed by gel or oxytocin. Yeah, thank you.
So I'm actually, we've already addressed this question about stripping. And we know the pharmacological methods. All of you love champion prostaglandins, like anything. And we have received Dr. Reena's input on Profess, which is really good. So if it's available in the market, I would say to the audience and to myself that we can start using Profess. Now, Foley's catheter, who has used and in only one condition, I would want you to tell.
We have the experience of using it, Dr. Mitra, and that was in cases of previous section. Previous section with IUFT, those were the conditions where we have used it.
Okay, very nice. Anybody is using low dose oxytocin infusion?
Mitra, I would like to say that I have used Foley's along with Survey Prime put together, especially in previous LSCS. I avoid using, of course, I told you I don't use Propes, but we definitely have used Foley's catheter along with the gel. Can be used 30 cc, you can inflate the bulb, particularly in previous LSCS. We in fact had a previous 2 LSCS with fetal demise, who was around 26, 28 weeks. So the issue was that we also have another scar. So we had with under controlled conditions, we have managed to deliver her vaginally. So I think we have to use our judgment, counsel, take high risk consent and document, and things can move forward.
Okay, so we find that misoprostol is a very nice drug, cheap and easy to use oral buccal vaginal. Vaginal route is the safest to use and dosage is 25 to 50 microgram, 4 to 6 hourly. And I'm happy to say that Dr. Sarita is using it. A lot of us are also using it. I stopped using it.
25 microgram is okay. 50 will be too much with a live fetus. In a live fetus, I think 25 is enough.
In primies, I'm using 25.
Okay, and I had meconium staining in amniotic fluid. That's why I stopped using Misoprost and I went back to Survey Prime Gel. Anyhow, we have, and thankful to Dr. Sarita to share this chart with us. So we can see that it is used, misoprostol is recommended in induction of labor, but it is not to be repeated very quickly. So 4 hours is the gap which is prescribed for induction of labor. And Survey Prime Gel, what is your frequency? Do you repeat it after 3 hours or after
6 hours? 6 hours.
So that's a clear-cut message. 6 hours, 3 times in a day, and you have 3.
Maximum 3 doses.
Maximum, otherwise 2.
Okay, fine. So,
I'm
Professor,
sorry, I have to intervene right now because
Sir, ho gaya.
we have
Thodi si der.
exceeded their time
Oxytocin.
limit, and Dr.
Sir,
Piley is
5 minutes
waiting.
more. 5 minutes more. So
No, not 5 minutes, madam. Please, the time is already up.
Thank
Kindly
you,
finish
Dr.
in 3
Mitra.
minutes.
Thank you, Dr. Ashish.
Yeah,
Thank you.
thank you so much.
Thank
Thank you.
you, Thank you, sir. Thank you, Ashish, sir.
Thank you so much.
Well,
I know that the discussion is going on
Dr.
very well.
Just you already mentioned all these things. Or any take-home message from all the panelists? I will stop my share, but before we have opinion of all the panelists, I will not stop. So, Dr. Ranjana, what is your giving message to the audience?
That is
Everybody, please smile because the photographs are being taken now.
Hanji, Dr. Ranjana, your one-liner.
My one-liner is that as far as possible, and if conditions permit, we should wait for normal and natural delivery to occur. Only because of increasing age, and if there are some medical complications, we have to induce labor. Then only we should go ahead, or if she's going post-mature. So we
Dr.
should not be
Sarita?
in a hurry to do induction.
Yeah, thank you. Dr. Sarita, what would be your one message you would like to give? Dr. Sarita, are you there? Dr. Abha, ma'am?
Yeah, induction of labor should be done for valid indication. And we should always weigh the risk of mother to the fetus. It should be beneficial and it should be done in a proper setting. And the patient and the baby should be monitored.
Okay, Dr. Sarita, what is your message?
No, I think thank you very much. You've given very, very valuable inputs. And I'd just like to say that, all induction should be indicated and done carefully and, should be done only when required.
Thank you so much. Thank you so much
Dr.
to the
Shobha?
moderator and the panelists, everyone. It's a wonderful
Ashish is not
discussion.
allowing me to speak. My final comment.
They're
is
going
not
to
taken.
mute us very soon.
I only wanted to say, Mitra,
Yes.
that it takes a lot of courage to induce, and one should not give up easily. One should not, as long as there is safety, one should not give it up easily.
But I agree.
Dr. Reena, to Dr.
Please
Reena.
focus on Dr. Shobha Goody. I'd like to take her photograph.
सर मेरा भी मैं बोलूंगी अपना भी लर्निंग ना डॉक्टर रीना आप बोलिए प्लीज डॉक्टर रीना वानी quickly.
Yes, tell me. I feel that we should have a properly selected indication, be patient, and give a full trial if you're inducing. Otherwise, you will end up with spiraling cesarean section rates. That is and failed induction of labor is one of the things we can control with proper choice. And here, the clinical judgment is important.
Thank you so much. And Dr. Ashish, please allow me to say my one-liner. My one-liner is, when you induce a patient, of course, as our panelists and experts have mentioned, everything has to be proper. But I try and tell my patient and their relatives, please be patient.
Exactly.
Sabr rakhiye, only then we'll be successful. We will take care that the mother and the baby are fine, and will not give up unless there is a complication. So wait and watch and give them time. So maybe 1 day, 2 day, it increases, but if we are safe, then we can be successful.
Nowadays, relative distress is very important indication.
Dr. Mitra, I agree with you because the patients are rarely patient. They are impatient, basically. So I think with that take home message, I'll close this session.
And Dr. Ashish is not patient with us. Thank you so much.
Thank you. Thank you so much, ma'am. Thank you, moderator. Thank you, expert, and all the panelists for such a brainstorming and a very wonderful panel discussion, which is ever ending, of course. So let's move on the last session. That is, there are 2 talks here, and to present this, we have one speaker on instrumental vaginal delivery, Dr. VP Palli. To chair this session, we have Dr. Suchitra Pandit. So, ma'am is a chairperson of AICC RCOG, president of ISOPAR 2018-20. She's also the president of Justices India Association, president of Foxy ICOG 2014-15, and president of Mumbai Society OBGYN 13 and 14. And she has a lot of title in her name, of course, and she's also the winner of Lord of Planet Award. So welcome, ma'am, to chair this session. We have Dr. Kasturi, but Kasturi, ma'am, are you there? Because she called me and she's has some network issues, so she won't be able to join. Dr. Kasturi, are you there?
Whenever she
Okay.
joins, we'll welcome her. No problem.
Yeah, so Dr. Kasturi ma'am, although she's right now not available, but she's the immediate past president and of KSOGA Society, and she's a professor HOD of Department of Static Kims, Hubli. So to for this, we have first speaker. So a chairperson, kindly introduce the speaker for the first session. Dr. Suchitra Pandit, ma'am. I think Ashish sir.
Yes.
I think.
Okay.
Will you take this honor to?
Yes. Dr.
Yes.
Suchitra Pandit, I think she is also caught on the other side of the network, I think.
Yes,
So
sir.
it's my pleasure to introduce my very, very, very dear friend and respected colleague, Dr. V.P. Paili, MD FRCOG. He is a past president of Kerala Federation of Gynecology, state coordinator of confidential review of maternal deaths, Kerala, and he is the one person who started this movement in Kerala, which has moved and swept the country. Entire country is now under fever of Dr. Paili's, maternal review, confidential review. Consultant, Rajagiri Hospital, Alavae, Ernakulam district, Kerala. He has got special interest in high-risk pregnancy, endoscopy, pelvic floor, and urogynecology. And we are all aware of his innovative techniques and many innovations which has moved many obstetric emergencies to a safer side. Welcome, Dr. Paili, and the floor is yours, sir.
Yeah, thank you, sir.
Thank you very much. Thank you, Ashish, Sarita, and ICOG in general for the opportunity to share with you our experience of instrument deliveries. I hope I am audible.
Yes, you are audible, sir.
Okay. Can I share, because I am aware of the timing factor.
Yeah.
So if I may be permitted to share the screen.
Yes. Please
yes,
share.
sir.
Okay.
Yes, it is.
Ashish, I hope it's visible.
Yeah, it's visible.
Yeah.
And you are audible, sir. Please.
Yeah. Mainly in modern obstetrics, we talk about two instrumental deliveries, that is the forceps and the ventouse. But as all of you know, it's a dying art. Why? Because we are not trying to keep it up. That's my feeling. There are many reasons people quote. In the US, in the UK, everywhere it is a dying art. I don't want to bore you with the evidence for that, but everybody knows, even in our country, instrument deliveries are becoming rarer and rarer, all because we resort to cesarean section very easily. And the reason for people abandoning, even seasoned obstetricians abandon it, because of the fear of complications. That leads to less use, less experience. Then people are afraid to use once in a while when they are asked to do it. And of course, finally they will abandon it. I think we can make it safe and reduce the complications if we adhere to standard protocols, proper case selection, modifying the instruments, and of course, the seniors give the training to the juniors. In our own instruments, we have about 20% instrument deliveries. And Dr. Mitra was saying about the induction of labor. Our induction rate is much higher. We use forceps to ventouse about 60 to 40. Of course, to some extent because of personal involvement. Forceps complications are as a result of when we try to do it in very high stations with incomplete rotation, poor technique of using it, and poor choice of instruments. These are my own observations. So we have to safeguard the use of forceps. The first thing is palpate per abdomen. Even though vaginally you feel the head is low enough, per abdomen also you palpate. You should apply it, forceps, only after full rotation of the head. If it is not fully rotated, you rotate it and make it sagittal suture anteroposteriorly. You do the direct application and you choose your instruments properly. I'll show you what we have done regarding the instruments. And then traction. You should follow the curve of Caras. But these days, people apply only after the head is at least +2 or lower, in which case it can be almost a direct traction like that. We follow what the Americans have said as 3 types of forceps, depending on the station. The mid, where the head is engaged, but not come down to +2. Most of the time, +1 to +2. The low forceps is one which has come to +2, but not low enough to satisfy the conditions of an outlet forceps. And what is an outlet? Head is at the perineum with the sagittal suture anteroposterior, or if at all, maximum a rotation or an incomplete rotation up to 45 degrees. So these are the types of forceps application that we recommend. Double check vaginal examination and feel where the head has come to the level of the spine, and per abdomen you palpate that, make sure that his head is not palpable. Digital rotation, I will explain to you. This is the principle. If it is an occipital posterior like this, you apply your index finger at the posterior edge of the parietal bone, and with the other 2 fingers of the other hand on the sinciput, you rotate like that, or the other way. That is what we do. I will explain this because it's an important part. I will just show you how you do it. You just put your finger there and the other hand over there and rotate it so that this becomes, the occiput becomes anterior. And once it has been brought like that, you can apply the blade of the forceps there to prevent it from rotating back. Now, this is possible. This is not forceps rotation. This is not manual rotation, just digital rotation. By that, once you make the head anteroposterior, then you can make it safer application. And when you pull, of course, follow the curve of Caras. Now, I'll just show you with the help of a video what we do for a low forceps application. This is the digital rotation being done. 2 hands, fingers to rotate to make the sagittal suture come anteroposterior. Then a direct application of the forceps. You can see the forceps is held and the left blade is chosen and directly being applied against your fingers first and then on the side of the head. So you get a biparietal application. When you have the first blade in position, depress the handle, bring the other direct application, bring the handle down to the previous one, lock them. If it is not locking, then adjust the handles. So, but remember, in the forceps which I recommend, our own modification, the handles may not come together. It may remain divergent. That is okay. And we give the application, the episiotomy, if at all, after the forceps is in place. You give traction, and when the head is about to come out, you may have to transfer your hand to the shank so that it doesn't open prematurely. So the occiput is out and then complete the delivery. Now, in cesarean section also you can, or you may need to use the forceps. So I'll just show you the basic principles. So you are opening the lower segment. The difference here is, once you have opened the lower segment, palpate and find out on which side the occiput of the baby is, and take the assembled forceps in your hand, rotate it, and find it's an occipital transverse position. The posterior blade is applied first, then you bring the anterior blade and pull, making sure the occiput leads. If it is not, if it's a deflexed head coming out, it will extend the incision and cause problems. So that is how we apply the forceps for delivery of the head during cesareans. Should we modify? I have no doubt we have to modify, because our babies are of different sizes that come out. You may, as it happened in one day in our hospital, there was an 875 gram 1.75 gram, 3.5 kilo, all these had to come out. And the same forces to be applied for all these is not really logical. So that is why we have modified the Western forceps, and this is Piley forceps. The biparietal distance is reduced. It is a shorter forceps. But then to take out these 800 gram babies, we have still brought a smaller forceps. This we call the mini forceps. This one is the standard forceps. You need to do this because otherwise, just like for different keyholes, you need different types of keys. These are the history. This is the as forceps. What you see over here is a more of a straight forceps and almost same biparietal distance, but it is longer shank. Das forceps, you know, we are proud of Kedarnath Das from Calcutta, who devised the forceps long ago. Now, the handles need not come together or may not come together. That is what you have to keep in mind. The modification of the forces that I incorporated are reduce the total length, reduce the pelvic curve, because we are not going to pull out the babies from a high station now. Reduce the biparietal distance, but remember the handles will not come together. They may remain divergent. The blades can be made thinner. With the currently available steels, you can make it thinner, and you can even give a Teflon coating for that. When the fetus is tiny, as I showed you, we need a mini forceps. Coming to ventouse is best suited just as a help out. If we need more traction from a higher station, we prefer to use the forceps. But anyway, ventouse, the advantage is it causes less trauma to the mother, but not to the baby. And American Family Physician has come out with this recommendation that you should follow a ABCD check to find out whether that case is suitable. A for assistance, address the patient, give analgesia. B for bladder to be empty. C for the cervix to be fully dilated. Determine the position or the rotation. But in the case of ventouse, it is not a must that the sagittal suture is under posterior. You can put it even transversely. Equipment check, you should make sure that your ventouse, whether you use the metal cup or the Silastic cup or the kiwi cup, any of these, you should check them before you apply it onto the baby's head. Make sure that there are no leaks. Make sure that your machine is working properly. And then, if it is the ventouse, it's a must that you apply it on the flexion point, about 2.5 to 3 centimeters in front of the posterior fontanelle. That should be the center of the cup. That is the flexion point. Gentle but steady traction. You abandon it if you feel there is no descent even after a decent pull, or if it pops off more than 3 times. And episiotomy may or may not. And the J is when the head is, the jaw is outside or reachable, you release the ventouse. So this is probably making it safer. Different types of cups, even the kiwi cup, even though we don't use it very much because its failure is much higher. Now, just to show you again a video to suggest some of the safeguards, you are identifying the position so that you can apply it at the flexion point. So Silastic cup being applied. When you are applying it, you should have an electronic device or even ordinary suction machine can be used. Previously, we used to say it should create the negative pressure step by step, but at the moment we feel that doesn't really matter. But once you have applied the cup onto the head, check all around to make sure that there is no maternal tissue caught. You can create the negative pressure without going step by step, taking 3 minutes and all that. Once you have it applied at the right place, then you give the traction. Same, follow the curve of Caris so that the head comes out, the perineum is supported, and when the head is outside or the jaw is reachable, as we said earlier, you can release the vacuum and get the head delivered. Now, at that time, we were sucking the throat, but now it is recommended that you don't have to suck the throat or the mouth. when the baby's head is just outside. This is a metal cup. We prefer the metal cup because that gives us better traction. And it has to be definitely applied onto the flushing point. The chain and the handle have to be applied, held at right angles to the cup. And when the head is out, you can just release and then take out. But even here, when the baby's head is coming out, you should make sure that here we are showing that ventouse can be used during cesarean also. Same principles. Whenever possible, try to see that the cup goes to the flushing point. But in case of cesarean, it really doesn't matter that much. But when the head comes to the wound, you make sure that the occiput leads, so that minimum stretching of the wound that you have created to deliver the baby. So this is a metal cup, but actually for a cesarean use, a elastic cup is easier because you have the handle and it is easier to apply. Our own preference is to use the elastic cup for a cesarean head delivery. Now, can we have sequential use of instruments? Because this is for ICOG and there may be students attending. The classical recommendation is don't use sequential instruments. We don't really agree. If you could not apply proper traction with the ventouse in the first place, and you abandon it, and you can go on to a forceps. But with the ventouse, you gave all the traction necessary, and still if it's not budging, here you can see that we gave reasonably good traction, but the head was not yielding. But in that process, the head could be rotated with the sagittal suture anteroposterior, and then we applied a forceps and delivered the baby. As you can see here, once that ventouse was removed, we applied the forceps, and then we could deliver with the forceps. So sequential, I think we should not say absolutely no, but you should be careful when one instrument has failed and when you want to go to the other, you should be careful in selecting the patient. That's all what I would suggest. The traction force required to deliver a fetus is equal to about 11.5 kilograms, and that much we should have. Forceps and ventouse, how to choose between the two? Our own working principles are, if it's a fully rotated or rotatable head, more traction needed if you feel, and if it's a preterm, less than 34 weeks, we go for the forceps. If it's an incomplete rotation and not easy to rotate digitally, if it's a low station and you don't anticipate much traction, and if it's a mature head, we go for the ventouse. So this is how we select which instrument in a particular situation. I thought I would just show this breech delivery because I saw we saw that Ashish had shown, and I thought the forceps that Ashish showed, even though he said it's a pipers, I doubt Ashish. I doubt whether it is Ashish. Is the pipers? It is a axis traction forceps, not a pipers. Pipers has got a perineal curve and a pelvic curve, double curve, and it should be longer than what you showed. That's my feeling. Anyway, we can use our ordinary forceps for delivering the aftercoming head. And you can see that here we are just ironing out the perineum with the breech there, giving the episiotomy, going up to the popliteal fossa and the pinard, and got the baby out. And the other point I would suggest is femoropelvic grip. Femoropelvic grip. Thighs, the thumbs parallel on the back, fingers gripping the pelvic girdle, going up to the elbow, pressing at the elbow, getting the upper arm drop out, and that rotation is the Lausser's maneuver. If the head is up there, that again is rotation, but I don't know whether Lausser's is the word for that. Anyway, wrap the whole baby with the upper limb and lift the baby's body up. so that you can access from below, from the ventral aspect of the baby. Feel that the chin is in the middle line. If not, rotate it and make it in the midline. And my ordinary forceps like this can then be applied to this one, which you are seeing. Same way, instead of coming from above down in the head leading situation, here go from below up. But the way it approaches the head is the same. So both forceps. Then bring the trunk down and don't give traction on the shoulder. Give traction on the forceps. And of course, it is not my mandate today to talk about breech, but one point, Ashish, which I thought that we have to emphasize is, you already did that, but I want to re-emphasize that. Traction from below in a breech delivery will make all the joints extend. It should be pressure from above. So we need two obstetricians to conduct a breech delivery, two people. The person at the top is more important than the person at the bottom. They should guide the head down. That's all. I thought I would, because I was listening to you, I thought I will share my thought about it. Documentation is important. Documentation is important in these cases. Can I just answer phone? I'll call you back. Sorry. In a meeting. So I think this is basically what I thought I will share with you. My allotted time is over. I don't want to go being seen that I am occupying too much on the stage. We should give good. So coming to the conclusions, I would suggest that it is essential to keep alive the art of instrumental deliveries. Obstetricians should be proficient in the use of forceps. No point in crying about high C-section rates. If at all you want to have vaginal deliveries, you should have the assistance of instrumental deliveries to complete it. Otherwise, a head which is low enough, in a no man's land, you cannot leave it. If you then try to take it by cesarean, it will be more complicated. So we should keep the art of instrumental deliveries, both the ventures as well as the forceps alive. And as I said earlier, choose the proper instrument for the particular situation. Thank you once again, Ashish and Parul. I saw Parul earlier, Parag, Sarita, Mandakini, all of you for allowing me this chance. And of course, Manisha, thank you very much.
Thank you so much, Dr. Paili, Professor Paili. Yes, you are right. It was not Piper's forceps because we do not have in our system. So that's why we use Das's forceps, the long curved obstetric forceps. Axis traction mechanism, of course, we do not use it these days. And yes, but technically speaking, as you said, I also found it that ordinary Das's forceps or even your forceps will be good enough for delivering the baby in after coming head of the breech. Now, the only advantage perhaps of the Pipers is a bit longer. So I think that if the head is a bit higher up, it may help. But under those circumstances also, we do not recommend to give the forceps that time. You have to wait for some time. But then this is all personal judgment. And as I said in my lecture, that the waiting time is limited. Only in 5 minutes in your hand you have, and you have to cover the baby with a towel. That's, of course, very, very important. If you want to prevent the premature attempt of respiration while the baby is still in utero. And therefore, these are the techniques that we normally adopt. But yes, I think forceps is a good method. But Dr. Paili, I have found in clinical practice, in my experience, the Mauritius smelly wheat technique is much more comfortable because that gives you a feeling that you are protecting the baby, making the head flex, because you are controlling the head position and then bringing it down. What is your opinion, sir?
Am I audible?
Yes, you're audible.
Yeah, personally, I don't think so, Ashish. We have recommended for breech delivery, for after coming head, the safest is the forceps, because that gives you traction on the head. Even Mauritius smelly beard, even though we talk about, if you could take away, I think they have put my slide over here. If you could take away, you probably can see me. Anyway, what I wanted to show you was, even in those cases, when the motor is smelly weird, if you are supposed to apply your hand like that, it's not easy to give traction on that. Whereas if you apply the forceps blade, that gives you traction. It helps you to keep the flexion attitude. And in the whole of obstetrics, the principle is flexed head produces less strain on the pelvis and the birth canal and easier to deliver. If it is deflexed, if it is extended, bigger diameters, more problems. So in our hospital, in our teaching, we say that if you are doing a breech delivery, use the forces for that. That is how we have been teaching.
Yeah, I tend to agree with you. The only thing what I take in the head in the cephalic presentation and breech presentation, the difference is a big difference. That means the head of breech delivery is not the same as head of cephalic presentation, isn't it? Do you agree?
Very true.
Because there is no
Very true.
molding. There is no, I mean, the head is relatively larger. It's bigger. It's not molded. By the act of molding, it undergoes.
I don't know who. I don't know whom to request to get this image out of that so that you can see.
Yeah,
what
I know.
am showing.
You just stop share.
I have stopped sharing.
Okay, Manisha.
Yeah.
Please remove this thing of Dr. V.P. Paili. We want to see each other. Yes.
Yeah. So
that's my only concern, and I have got no issues about the forceps. But the forceps today, I am having some training issues with forceps delivery as well. However, we can discuss it over some length of time in some more bigger platforms. Now is the time to call upon our next speaker. Manisha, please.
Can I just answer what you said?
Yeah.
You said that the head is different. Very true. Not only, as you said, the head is supero-inferiorly compressed, so the bipalatal is wider. All the more reason why we should have a better traction. Because flexion alone is not enough there. You need better traction. Because supero-inferiorly compressed head, bipalatal is wider. So unless you have something to grip around it and give traction, when you give traction by just bending like this, that is not good enough. That's my point. Anyway, as you said, we are very much constrained on time. And so please go ahead. Thank you once again, Ashish.
Thank you so much, Dr. Paili. It was a wonderful discussion. And I wish to go on with you for some greater length of time because this art of instrumental vaginal delivery is dying, as you correctly said. I hope we will get some messages in future and more and more practices, and only few obstetricians are practicing this. I think we should promote this for the benefit of our younger postgraduates. Thank you so much, sir.
Thank you.
Yes.
Yeah. So the next we have the next talk that is on alternate birthing position by Dr. Poonam Verma. Ashish sir, please.
Yeah. No, the chairperson hasn't come now. No, I mean, no, none of the chairpersons are there. Have you called them?
Yes, sir. No, they are not there, sir.
They are not there.
I can share my screen.
Yeah, sure. Dr. Poonam Verma speaking, no?
Yes, sir.
Okay. Yeah. So let me introduce Dr. Poonam Verma. Dr. Poonam Verma Shiv Kumar is professor and head of OBGYN MGIMS Sevagram. Sevagram is the place, a famous place, and it is famous for obstetrics. I know many people from Sevagram, and it's a wonderful institute. And she is a professor and head there, Dr. Poonam Verma Shiv Kumar. Advanced training in SHRH from Uppsala University, Sweden. Principal investigator for PPH bundle project in Harvard University. TAG member in India Biomedical Research in HIV and ICMR. Resource person and expert for Government of India and Government of Maharashtra for national guidelines development in maternal health. Nodal officer on FB-MDR committee. Member of core committee of MCH diploma IGNO. Contributed to Government of India toolkit. Recipient of awards as Doctor's Award for Management and many other, given 126 guest lectures, presented paper, chaired in international and national conferences as IMA, FOXY, IMOGS, NOGS, GCC in Sri Lanka, China, Thailand, Sweden, Finland, Kenya, UK, London, etc. 59 articles in the international and national journals. So here it is Dr. Poonam Verma. Poonam Verma, the distinguished faculty, who will be speaking on Dr. Poonam Verma will speak on alternate birthing positions, a very favorite topic of our chairperson, Dr. Parul Kottawala. Yes, Dr. Poonam.
Sir, is my screen visible?
Yes, it is visible and you are audible.
And is it moving, sir?
It's moving. It's moving.
Yeah. So thank you so much, my seniors, colleagues, and dear students. Today, what I am going to talk is nothing new. But yes, it was lost for a number of years and now it comes back again. So what I'm going to talk to you is about the alternate birthing position, which is a very important component in respectful maternity care now. So I bring greetings from Mahatma Gandhi Institute of Medical Sciences and also from the Mother and Child Health Wing, which is a model wing which we have created at MGIMS Sevagram. So outline of my presentation today would be that I would like to talk a little bit in introduction about alternate birthing position. I would also like to talk why different positions are needed and what are the advantages. Then what are the various positions and their advantages and disadvantages? What are the props which are needed for alternate birthing positions, and a bit of evidences and literature. So friends, we all know that alternate birthing position, when we talk about mainly labor, and labor is full of emotions, unbearable pain, but it ends up with happiness and joy, and that is what all obstetricians want. We also know that the first and second stage of labor is there and they are most difficult. In research, we see that the first stage is divided into latent and active phase, where active phase is very, very troublesome. And the second stage is propulsive and expulsive. And this is the time when the women feels extreme of pain. There's a very interesting history about birthing position. And if we remember, Cleopatra had given birth in kneeling position how many years ago? So if you go into the last 200 years, most of the American women, they started delivering in the, while lying flat on their back, we call it dorsal position. If you see, these are the ways which probably the history says that this is nothing new. The lateral positions, the chair positions, the squatting position, they have been used long time back as well. Why alternative birthing positions are needed and why are we talking about them so much? Because the changing position not only help the women to cope up with the pain of labor, upright positions, they use gravity to bring the baby down, whereas changing position frequently moves the bones of the pelvis and help the baby to fit in properly so as the women can deliver as early as possible. Now, during birthing, our aim is to help ease discomfort, move the baby down through the pelvis, and encourage fetal positioning. And whether you do it upright or non-upright, the baby definitely comes down, but the position varies. If we go into the Government of India sayings, which I categorically say because I still believe that we do follow all ACOG, RCOG, all guidelines, but we should believe on our guidelines which are related to our women. So alternate birthing position favors childbirth by creating some more space in birth canal. Movement of sacrum, ilium, and femur are essential to create an extra space. And there are two words used, nutation and counter nutation. And these are nothing but the movement of sacrum and increasing the space of the pelvic outlet and inlet. So counter nutation helps in creating space more in the pelvic inlet, whereas nutation increases more space in the pelvic outlet. There are some flexible sacral positions which are very, very important because again, they increase the pelvic inlet and outlet. There are several positions like standing, squatting, semi-squatting, side lying, kneeling, and all four positions. These are sacral positions where the sacrum moves and it moves and creates the space. There are also positions like lithotomy and dorsal positions where probably sacrum does not move. Internal femoral rotation tenses the muscles and ligaments located above the hip and increases the pelvic inlet. Internal femoral rotation also increases the pelvic outlet by increasing the ligaments space. When pelvis moves up and down and sideways during walking exercise and rocking movements, baby's head negotiates its way through the narrow birth canal also and makes the vaginal delivery easy. So what are the advantages of alternate birthing position? Movement and upright position create more space for the baby. So baby moves quickly inside the pelvis, and this reduces your interval of delivery. So right from the active stage to the delivery interval reduces significantly. It can change the shape and size of pelvis, which may support the baby's head to move into the optimal position during first stage of labor. And it also helps the baby with rotation and descent during second stage of labor. Gravity helps the baby's descent. Movement and upright positions can help with the frequency, length, and efficiency of the uterine contraction. And it has been seen that when the woman is standing or when the woman is in the gravity position, probably there are more frequency of contraction, which again helps in the delivery. So the effect of gravity can help the baby to move down quickly. It shortens the duration of first stage of labor by nearly 90 minutes. So there are literature talking about it, and this reduces the length of labor. Now, what are the advantages of alternate birthing position when we talk in terms of evidences? And I'll show you what are the evidences. They again suggest that the duration of labor from 3 to 10 centimeters cervical dilatation, if you look into 50% shortening is there in standing position than supine position. Sitting position, they help to ensure the continuous oxygen supply to the fetus rather than causing supine hypotension, which is there in lying down position. Squatting and sitting position decrease the likelihood of cesarean section by 30% and reduce the need of epidural by 20%, and decreases the abnormal fetal heart rate pattern as compared to horizontal position. Moving around and changing position supports the pregnant women to discover ways to be comfortable during labor. It reduces pain, it distracts her, and it enhances the sense of control. It all gives her great birthing experience, which is the key for the respectful maternity care now. Now, what are the various alternate birthing positions? So we all know there are two varieties of alternative birthing position. One is flexible sacral position, which takes the weight off of the tailbone. And these are kneeling, standing, hand and knee, side lying or lateral, squatting on the chair and using U-shaped birth seats. And then there are non-flexible sacral position, where the tailbone is the place where the mother rests. They are supine, semi-sitting, and lithotomy. Hydro labor is something very different. And in this hydro labor, which I'll talk to you in a minute, here, you can change the position, not necessary that she has to lie down right on the sacrum. She can change her position in the water. And finally, while she's delivering, she can lie down or she can be tilted on the lateral side. Now, these are the birthing props, which are very easy to get. And if you really look into, these are birthing chairs, which we have developed on our own. A simple armchair, which has been made very comfortable for the women to sit and deliver and take the baby on her breast from herself from the tray. And then, of course, the small stools for the people to sit. Then there are bars where she can squat. There are balls on which she can rotate. This rolling on the ball increases the pelvic capacity as well. Ball and rope together, and of course, hydro labor, the very interesting way of delivering the baby. These are very special chairs which have been made in, we are advocating it. So Loni Medical College, Dr. Bengal has made these kind of chairs which are very, very comfortable. Now, when we talk about birthing position upright, literature very clearly says that if she is upright, the gravity can help bring the baby down. There is less risk of compressing the mother's aorta and better oxygen supply. So all the way around, and if you see, the whole world is now looking into the upright position for delivery. And then, of course, the uterus contracts strongly and efficiently when she is upright. And MRI dimensions have been checked. the pelvic outlet becomes absolutely wider when you talk in terms of upright position. Finally, upright positions increase maternal satisfaction and they give a very positive birthing experience. So if you look into this chair, it helps relaxing the perineum. Women get used to open leg position, uses gravity, and women can pick up their own baby and latch on themselves. Only problem is there is pressure from the toilet seat, which may be uncomfortable. So seats are to be made very comfortable. Birthing balls are being used. They again, if she's sitting on the ball and trying to spread her leg and delivering, then it uses gravity, gives good oxygen, contractions are effective and less painful, and it speeds the delivery. And there is a pushing urge much more in these ball labors. The problem is that there is poor control at birth, and sometimes for healthcare provider, it is difficult to see the baby. When we talk about leaning forward on bar or props, again, it realigns the pelvis to increase opening by 15%, allows to be supported, takes advantage of the gravity, makes contraction less painful, lengthens the trunk and helps the baby to align. Movement helps baby through the birth canal and may increase the urge to push in second stage of labor. This is the most convenient position where we all want to deliver the women, but believe me, this is not really a right position in which we should deliver. Now, lying down position, though it helps to get the oxygen to the baby, but not really the way upright positions do. But these lateral positions, they do help. Good resting position. It is very fine when the epidural has been given. Partners can assist good uterine contraction and relaxations in between. There are lower chances of tearing or episiotomies, and there's very good access to the perineum when she is delivering in the lateral position. Only thing, to see the fetal heart or hear the fetal heart sometimes may be a problem, but gravity here does not help. Lying on the side, again, it reduces the length of active pushing. The rate of episiotomy using forceps, vacuum, fundal pressure all reduces. So this is again a position which is very, very recommended. And this is something which is very interesting, and we have delivered number of women in this position. The perineum is absolutely visible. There are no tears. So this is another interesting thing, a position where we can deliver the women. And then comes the hydro labor, where we have almost done nearly 70 cases. In this, why women delivers much earlier? Because the stress hormones are reduced. The pain relieving chemicals released in excess. Labor pains are reduced markedly, shortens the duration of labor and reduces incidence of instrumental delivery and reduces cesarean section rate. So these are the references which I have seen, and whatever I have spoken to are there in these references. You may kindly refer to these references. And now when we are talking about birthing position, we are seeing that in US hospitals, it began from there that everyone was made to lie down on the back. Everyone was made to sit in the dorsal position. So this is the US hospitals data, a combined data of number of hospitals. Birth lying on their back, 68%, semi-sitting lying 23%, side lying 3%, squatting only 4%, and hand and knees 1%. There was a meta-analysis which found that the people who are with epidurals being upright during the second stage of labor, there was no difference in the rate of cesarean section, forceps vacuum, perineal tears, and abnormal fetal heart rate pattern or low cord pH or an ICU admission. So people who say that if you are in upright position, it would be very difficult to see and the baby may have problems and go to an ICU, those things are not really right. When we talk about ACOG clearly mentions no one position is needed to be mandatory, or it is not prescribed when a woman is delivering. So she can use different positions. and she can choose. So it is her right as well when we talk in terms of her choice. So it is a right that she should be given freedom of movement in labor and freedom of choosing the birth position in which she wants to deliver. RCM also says that there should be variety of props available in the room to encourage people to try different positions. Even upright positions have been recommended. And if you talk in terms of midwives, midwifery, which is coming up here, and our center being the first nodal center for the midwifery training in the government setup, we are seeing that these midwives prefer having an upright position rather than lying down position. Even WHO concludes that the women in labor should adopt any position of her choice. And when we further go into the literature review about birthing positions, so around the world, even though people are preferring only non-upright positions, but the textbook now are saying that we should go for the upright position because the benefits are too many, especially for the first mother. Now, this is another Cochrane review and meta-analysis by Gupta et al., where 9,000 births of people were seen, and it was realized that with the alternate birthing position, there was 25% less likely forceps and vacuum-assisted delivery, less episiotomies, less abnormal patterns. There were tears, second-degree tears were more, but at least episiotomies were reduced, and the estimated blood loss was slightly higher in some alternative birthing position. So I'm going to share with you in a minute our experience of 18 months, which we gave it as a thesis, and also the experience along with the midwife. So this is what we did. We took two groups. In one group, 500 patients were there with dorsal position, and in the other group, 350 patients were there with alternate position. So these are the alternate positions which we used. In the second stage of labor, there was significant statistical difference which was found in the length of second stage of labor. You can see here that it was significantly reduced. When we took in terms of pain on an NRSS scale, we realized that the pain level was much lesser when we did alternative birthing position. And instrumental delivery was significantly reduced in alternative birthing positions. Perineal tears certainly were more, but episiotomies has significantly reduced in the alternative birthing position. And when we compared the second stage of labor, we realized that the second stage of labor was maximally reduced in hydrolabor. And when we looked into the cervical dilatation rate, again, the cervical dilatation was much more in hydrolabor. Of course, the second one was the chair leg. So midwifery is a very interesting initiative in India, and we are very happy to say that after the midwifery coming here, now we all know what is physiological birth. Why we should keep your hands away from the women, why we should not repeatedly, use PV examinations, or we should, do ironing and so on and so forth. So these are lost arts now. We should never try. Just leave her alone, give her some time, let the baby restitute, do not hurry, and you will see that you will find a natural birth without any complication. Everything in the natural lines of the body. Now, this is the hydrolabor which we conducted. This lady was a swimmer and she wanted hydrolabor. And a minute, I'm going to show you can you please help me for the video? Yeah.
Where is the video? Yes.
Yeah, just see I'll very quickly pull it ahead so that you can see how the baby is delivering. And the women enjoyed herself in first stage of labor. She was reading books. She was talking to her people, was very comfortable. And see, this is no touch technique, off hands technique. The baby is used to the liker, so there is no problem if baby comes out. But the moment baby comes out and before the first breath, You have to ensure that the baby is taken out of this thing.
Water.
No touch technique, nothing. We are not touching the baby. 1 minute, could you please help me? Yes. It stopped in between. Either you stop it and restart it.
Yeah, Dr. Poonam.
Yes, sir.
I think it has stopped responding because of the video.
Yes, sir. So I'll just close that, sir. Give me just 1 minute. I'll connect again from the current slide. From the current slide. Yes. Can you make it full screen? Yes. Now you bring it ahead, please. So this was hydro labor. And then, of course, we can have it on the semi-reclining on the chair. And this is what the chair labor is. These are the videos which we have saved. We don't have much time, but we will just show you how they deliver. And it's just a handoff technique. This is how baby comes out. And the baby goes to the mother. How do we go back? Okay. So these are various positions we just wanted to show you that this is doable. It is not something like this that you can't do it. Can we make it slideshow? Slideshow. Yeah. So this is again, we are doing advocacy and Pravra Institute, Loni, NKP Salve. We all are now doing these alternate birthing position. These are chair labor. So I'm not going to show you the video. We can see the videos later on. So how do we set up alternate birthing position in LDR? And this is the way you can do it. Please do a PDSA cycle. Ensure that you train your people, get the props, give the skill training to the staff and doctors, introduce midwifery, where counseling, implementation, and then of course do data analysis and look into the way things can be done. And what is desired is that somebody has to take the leadership. There has to be technical and non-technical support. There has to be administrative support, a teamwork. Please follow all evidence-based protocols, go into the literature, look into it. And when we started, we ensured that we go to the Fernandez Hospital, see everything there. And then coming back, we ensured that we do it according to our rural patients' need. And of course, a little bit of financial support is required. So if you say that alternate birthing position and you need so many things, no. These props are very cheap. You can develop them on your own and everything is doable. So my take-home message at the end is that alternate birthing positions are the key to RLC as it encourages physiological birth. It is the right of the women. Counseling and training are two mandates. Props can be developed very easily and it is doable. Skill practice in labs help in much better training. And the first thing is that we have to change our mindsets. Certainly, it is going to reduce your cesarean section rates. We in the tertiary care hospital, we were going as high as 43, 44, 45, 50%. We have come down to 33% just by using these techniques and midwives. Thank you very much. These are my references. So let's make childbirth moment very memorable by using this alternative birthing position. Thank you for your patience.
Yeah,
Thank you very
thank
much.
you.
Yeah, Dr. Poonam Shivkumar.
Sir.
It's an excellent presentation with a lot of videos. And it just showed that it's just a mindset that we cannot change the position of the laboring woman.
Sir.
That you have mentioned adequately in your lecture presentation. Exceedingly good presentation. I'm sure it is stimulating for all of us and a lot of learning experience for all of us. And with that note, I would like to thank you so much profusely on behalf of ICOG. And I would like to request Dr. Asha Jain kindly to come back to the chair and chair the last session of the day.
Thank you, sir. I'm very much there and I have been through these excellent presentations.
Oh, yes.
Each speaker has actually spoken from the heart. And Dr. Poonam, every time I hear her, whether it is PPH or whether it is this birthing position, it's coming from her heart how to ease the pain of women. So congratulations to you, ma'am.
Thank you, Asha. Thank you so much.
And now I have already introduced Dr. Sharika. Do you think I need to introduce her again?
No, there is no need to introduce once again. Just call Dr.
Dr.
Sharika.
Sharika, I request you to share your screen and start the program, because after all these procedures which make labor look like a pain, your take on how labor can be painless, how we can reduce that pain and increase normal labor is
Dr.
going to be
Poonam,
invaluable. So in
Dr.
a way, it's
Poonam,
good
yeah,
that it
Dr.
has come
Poonam
at the end.
reduce 50%
So
of the
welcome,
pain,
Doctor.
and rest 50% is up to Dr. Sharika. Dr. Sharika, can you share your slides, please?
Yeah, sure. Thank you for the slides. Ma'am, you're very much not audible. Your voice is very
Your voice is
low.
breaking actually, yes.
Yeah.
Can you share your screen, madam? Dr. Sharika Roy?
Yes, sir. Yeah. Dr. Sharika?
Are we ready?
Yeah,
Yes.
you have to just share your screen, your presentation. There is a share option.
By the time they are organizing the screen, can I give you a demo? Basically, I'm supposed to be talking about pain relief during labor.
Correct.
Right. So let us talk very non-formally, without having a lot of presentations. They are coming on the way till they manage to get my PPT on the screen.
Okay, admin,
We
can I
all
request
know
you
as doctors.
to focus Dr. Sharika? Hello?
Yeah. Yeah.
Dr. Admin, can I request you to spotlight Dr. Sharika?
Yes, yes, sir.
She wants to have a presentation without slides.
Yes, sir.
Yes. Thank you. Yes. Please start, madam.
Yeah, they want to see the slides. Till the slides are on, can I speak?
No, no, no. You speak. There's no need to go
Yes,
for.
ma'am. That is why your face has been spotlighted. You can
Yeah.
go ahead and
Yeah,
start
because
speaking, ma'am.
I believe all my slides are made from the internet and from Google. So that information is already there. I believe what I'm here for is what I am getting out of my personal experience after going through Google and everything else. So those slides will definitely follow, and somehow I've not been able to catch on to them.
It's no need to go through the slides, madam.
Wait, ask them to let the Dr. Nisha let.
It's not necessary to go through the slides. You please
Yeah.
start speaking now.
Yeah. I would. Yeah, so we are talking about pain relief during labor.
Correct.
The trend that I'm seeing, that we all, not only me, are seeing, and we all know, and we have to agree upon it, that everybody is more going towards cesarean section, and doctors are being blamed for it, for which I defend every day. It's not we doctors who want a cesarean section. It's now what the trend is, that the patients themselves opt for a cesarean section because they don't want to go through that ordeal of a pain. So, so comes the critical issue of how to make the patient, and why should a patient go through a normal delivery? After all, there are a lot of questions that our patients ask us. I'm sure you all go through it. इसकी अगर मुझे 2 ही बच्चा चाहिए and हम cesarean के लिए तैयार हैं, तो हम normal क्यों करवाएं? Why should I go through that ordeal? And why not go for 2 elective cesarean sections? This is the first question most of our patients ask, and we all comply. Yes, you're right. And so we opt for an elective cesarean for most of our patients nowadays who are not ready for the labor pain. So to begin with, I think in this topic I should be talking about is why is normal delivery still a very important issue to be dealt with versus a cesarean section. So are you all agreeing with me for this? Anyway, irrespective of the answer, I feel I'm
Requesting you, ma'am, please go on speaking. You can cover your topic, no issues. Please go on speaking.
Yeah, I just want to know because firstly speaking, if we are spending time together, all of us are tied up with time. And if we are spending time together, we definitely want to know somebody else's experience and how we can improve ourselves tomorrow in our own practice. So to begin with, are we all convinced that a normal delivery should be the first choice of a woman's way to deliver?
Yes, yes.
Me, there are a lot of reasons why one should go for elective CS. I personally tell my patients so. One, you have a safe delivery, unless you have the anesthetic risk and postnatal issues and whatever. Your future obstetric history is put on a check. Number two. Number three, how the theory says is that the bonding between the mother and child is less for a cesarean section, which I would disagree because I love my children delivered by cesarean section more than I would love anybody on this earth. So I disagree with that bonding factor. The disadvantages of a normal delivery are much more mammoth. They are like you are ruining a vagina, which is the cause of a lot of satisfaction in any married life. You are IQ of a baby through a normal delivery is definitely lesser than one with an elective cesarean section, which is very much documented, and I personally will document on it and stand by it. But all these side effects of a normal delivery and knowing the benefits of a cesarean section, I still opt for normal delivery being the first option, because we do not know the future. If I put myself personally on the field, had I been delivered by normal delivery in the last 3 pregnancies that I had, I would have I had to go for a surrogacy, and I was a surrogate for 2 of my twins. And had I been a case of normal delivery, I would not have been delivered as a preterm patient. I would have carried my baby with a lot of uterotonics and pushed my baby, not put it into incubator, and things like that. So normal is normal. उसकी जो side effects है उसको हम लोग कम कर सकते हैं. Episiotomy should be done by more experienced people. The vagina should be restored to as close to normal, and normal delivery should be made as good a trip, I think a woman has, which nobody else on this earth can. Your husband can never experience this. So it's for us gynecologists who should advocate normal delivery in a way that it is acceptable. It's like a picnic. It's like an event in somebody's life. You know, going in for a cesarean section or going for a hysterectomy, like nowadays has become the same. So, you know, we as gynecologists play a lot of role in changing the mindset of people, because cesarean has become a very convenient a lot. And I think this should come to a stop. And what would bring us to a stop is making normal delivery pain-free. So now when we come to a normal delivery being pain-free, we have a lot of ways, and the most advocated way is epidural, which I'm not going to be touching upon because I think everybody knows about it. The pathways of pain relief and everything. What I'm asked to talk about today is epidural. Sorry, it's about Entonox. So here we have a patient with us. She just delivered a few hours ago. This was her second pregnancy. Her first pregnancy was like any other normal labor, and she went through almost 4 days of acceleration of pregnancy and induction. This time she was induced at around 12 o'clock. She was given her nitrous oxide, which is here with us. This gas, she was asked to inhale this gas as per her convenience. So, unlike every other pain relieving unlike every other pain relieving documentations, here the patient plays the role. The reason PPT छोड़ दो. It's unnecessary. Here, I personally feel that here the patient plays the main role, and here the why doctors and hospitals are not very documenting it. One, I would say a little bit of cost effect, but it is not so cost effective. And number 2 is you need to be with the patient for almost an hour, you know, half an hour to 1 hour, because training the patient how to take the nitrous oxide is one very big issue. Unlike epidural, you take the patient into OT, you put the epidural and you're done with it. So in this era of, a lot of patients and less time, epidural turns out to be a more convenient way to deal with pain relief in labor pain. Nitrous oxide requires a lot of personal attention and a lot of personal motivation. जब पेशेंट बहुत दर्द में होती है, her first reaction is हमको कुछ नहीं करना है. So she is not ready to inhale. She is not ready to take the gas. So this is where we have to tide over. This is where you need a lot of tender care, loving care, जो हम लोग शायद अब नहीं दे पा रहे हैं, या हम लोग का जो वर्किंग टीम है वो नहीं ट्रेंड हो पा रहा है, एंड वी आर नॉट एबल टू गेट ऑन टू दिस. You have to have one-to-one assistant is not possible, I think, in India with this workload or whatever. So maybe that's because nitrous oxide is one labor anesthesia which I took 28 years ago for my first son. And I took it because I was a VIP patient. Dr. Shanti Roy ki bahu thi, and the anesthetist was there with me. One-to-one hona hi tha. And I got this idea from my sister-in-law who was delivered in Australia, which again has a population issue. They don't have a population. So, these are the things that we need to work on. If you want oxide, which is safe, which is self-administered, she need not take it when she is not in pain. She takes it only when she's in pain. The onset of action is within 30 seconds. And the offset of action is equally fast. There's practically no side effect unless you have any lesion in your body, which is a space-occupying lesion, because this gas goes into spaces. So if you have a pneumothorax or you have some space-occupying lesion in the brain, you pain-relieving drugs. And it is totally in control of the patient. You need to give 1 hour with the patient, not you personally, maybe your assistant who is trained. And this would become the most rampant way of getting pain relief, I think, if it can be advocated very well. There are a lot of slides. Would you just go through them?
Madam, please continue. We have to wind up this
Sir, I
session.
would like to talk to the patient who has undergone this just a few hours ago. आप अपना एक्सपीरियंस शेयर कीजिए. एक्सपीरियंस शेयर करो.
एक्चुअली फर्स्ट टाइम बहुत ही हेल्पफुल रहा है. मेरे फर्स्ट बेबी में बहुत मैंने पेन सहा, लेकिन सेकंड बेबी में मुझे बहुत ही अच्छे तरीके मतलब नॉर्मल तरीके से एकदम बिल्कुल पेन नहीं हल्का.
One more advantage is the accelerated labor. You must go through the pain pathway. How the pain pathway prevents cervical dilatation. So अगर किसी पेशेंट को अगर आप पेन रिलीफ करा रहे हो किसी भी तरीके से, you are helping cervical dilatation. This woman delivered, I think, within 1.5 hours of taking nitrous oxide. These are advantages of pain relief. So these things have to be taken into consideration. And normal delivery is taken as a, ये सब कोई होता है, गाय भैंस को भी हो रहा है, like, it's only we are scared of maternal death and fetal death. Maternal death, fetal death. These are the two aspects that we're looking into, and we are cutting open people because we want to tide over these two crises. So this needs to be looked into a more detailed way. Of course, fetal death and maternal death will remain the priority forever, but even these critical and emotional things of pain relief, being with the patient, it is basically time consuming. So what we need to do is paramedics को motivate करना, उनको उतना उतना whatever उतना importance.
Your voice is breaking, madam.
That they're a part of a system. If this thing from the institute, we are not going to be getting into a system. Every paramedical, but you cannot be the one earning everything. You will be the one who will be earning a name. So these things have to be looked into. This is my personal view.
Okay. Thank you very much, madam, for sharing a different
very
kind
much.
of experience. First-hand experience of a patient talking about pain relief in labor. So I thank you profusely for sharing this experience with us. Yes, it was a thoda different presentation. I agree with that. But then we are able to hear the patient herself that she is not
No,
comfortable.
but she
Thank you so much for this. And madam, your voice is breaking actually. You have a poor network connection.
काफी कम टाइम में मुझे बेबी हो गया, बेबी बॉय मुझे आज हुआ है। इसके पहले मुझे एक बेबी हो चुकी है, बेबी गर्ल थी मेरे पास, उसमें बहुत मुझे टाइम लगा था। 4 डेज के लिए यहाँ एडमिट थी, बट अभी मैं यहाँ पे 12 बजे 12 o'clock मैं यहाँ पे एडमिट हुई थी और मुझे 3 आवर ही लगे। और ये जो नाइट्रोजन गैस है ये मेरे लिए बहुत ही हेल्पफुल रहा है और ये मुझे बिल्कुल ही पेनफुल मुझे लगा ही नहीं कि मैं बेबी भी नहीं कर रही हूँ। बहुत अच्छी तरीके से मुझे बेबी हो गया और पता भी नहीं चला।
ठीक है, we got your point. Thank you so much, madam.
इसमें थोड़ा सा सर expense is a problem because the gas is little expensive and plus monitoring आपको वो use कर रहा है. You need to have a very good staff. You know, because अगर मान लीजिए you are I'm talking about very practical issues which should not come in the books and in papers, and I think that's why we have conferences. We don't have conferences for what knowledge we are going to get from the books as it is. So these are the practical issues that you will face. Your staff should be honest. They should know how to monitor, photograph as where is the parameter of the cylinder and after usage, kitna parameter hai. So, you know, these are thoda sa issues why I think nitrous oxide has not become famous.
Yeah.
Like for epidural, you give it one shot and you're done. And every 3 to 6 hours,
You
whenever
have said that, madam. We have heard from you. Thank you, madam. And now I invite Dr. Asha Jain, madam. Dr. Asha Jain, she's there and she will give some concluding remarks on this presentation and of Dr. Poonam.
No, sir.
Dr.
Sorry.
Sharika. Dr. Sharika, right?
On Dr. Sharika.
Dr. Sharika, yes. Sorry.
Well, sir. Sir, see, if there is pain relief, when I was doing my PG and my topic was paracervical block for labor, you know, when the patient doesn't have pain, the neurogenic pathway doesn't work as well. And therefore, you know, that cervical contraction, lack of dilatation, all those things go away very fast. So I think pain relief is something, you know, so many cesareans are done for the so-called cervical dystocia. Cervix is not dilating. At least if there is no CPD, no other obstetric problem, then this aspect, if it is taken care of, we should have more easy dilatation and progress of labor. That I'm sure of. If nitrous oxygen is doing the trick, all good. But whatever we have in our armamentarium that we can offer is something we should be offering. So thank you, Sharika ma'am. You presented in a very novel way, but interaction with the patient was a silver lining because it is basically we are talking for the patient. And if the patient is happy, that is the major thing. So thank you very much. Thank you, Ashish sir, for having me here.
Yeah. Thank you, madam. Thank you so much. And thank you, Dr. Asha Jain, for chairing this session. So every good thing has to come to an end. And today we have come to the end of this session. And at this point in time, I would like to thank immensely Dr. Sarita is here. Dr. Sarita is here.
Yeah, I'm very much.
Okay. Dr. Sarita, would you like to propose, say something or propose vote of thanks?
I would like to thank सबसे पहले तो पारुल sir. I've like totally left all the academic issues because I'm very much now become a housewife and deal with my pregnancies because that's my passion. So Parul sir is one person who drilled me back into this academic field. And
Yes.
a vote of thanks to मैं सबसे पहले उन्हीं को दूंगी.
Dr.
Thank you very
Parul,
much.
are you there? Dr. Parul Kurtawala, are you there?
Even
No.
if it's not, please tape it and send it to him.
Yeah. We'll do that. We'll do that. Thank you so much, Dr. Sharika, and thank you all my faculty.
Thank you so much.
For everyone has done justice to their own subjects, and in the end, I like to thank my two MOCs, Dr. Manisha.
Thank you, sir.
They have done a wonderful job. I can't see Mariam, but I think she has left for some purpose.
Yeah, she has left.
Okay, it doesn't matter. So thank you, the chairperson. Thank you, the coordinators, and thank you everyone for making the program a grand success. On behalf of ICOG, we would like to invite you to further programs as and when declared by ICOG. Thank you so much.
Thank you. Thank you.
Who's this program? Thank you so much.
Yeah, thank you.
Good. Very good.